presentations. And in fact, the second session will be on an integrated session where we have invited guests from National Program for Control of Blindness, Dr. Indu and Dr. Rajesh, and also from Vision 2020 Right to Sight. And we'll be having some presentation on related to our planning in India, related to National Program and Vision 22 Right to Session. The third session will be chaired by Professor Radhika Tandon, and she'll be talking about low vision clinical services, mainly by RP Center. And the fourth session will be on vision rehabilitation, where whatever vision rehabilitation activities are being conducted at RP Center, we'll be discussing about those sessions. So in the first session, I would like to talk about the community ophthalmic journey at RP Center. And in the beginning, I would like to thank our chief, Professor J.S. Tityal, and he was recently taken over as chief. And under his vision, we are organizing this workshop. I would like to remember Dr. G.V.S. Murthy. In fact, 30 years ago, 1992, he was the first faculty of community ophthalmology in RP Center. In a way, he is the father of community ophthalmology for us. And it was his vision that he started a lot of community outreach, research, training programs in RP Center that include mainly the India-UK project, INDI project, Indigen project. He also led National Blindness and Visual Impairment Survey in 2001 and 2007, and also National Trachoma Survey in 2006. And in fact, he is almost like a mentor for us. He's a fatherly figure. Today is his Father's Day also, so we remember him on this special day. And it is now, at present, I'm very happy to say that the community ophthalmology section in RP Center, it is not one or two people. We are a team of 80 people, 80 people, and it's a big achievement for us, and we are working a lot. In fact, the key activities which we are currently involved are primary eye care and vision center services, reach-in program for cataract surgical services, low vision and rehabilitation services, technical support for National Program for Control of Blindness and Visual Impairment, lot of community-based epidemiological studies to provide data for the country. We are also WHO Collaborative Center for Prevention of Blindness, and also some activities along with Vision 2020 Right to Sights. So I'll be talking briefly about these various activities which RP Center able to lead in country in relation to all these aspects. The first thing is nowadays Government of India is giving a lot of emphasis on strengthening primary eye care, and with the help of vision centers, I welcome Professor Radhika Tandon, who is the chair for the entire workshop. Welcome, ma'am. So in fact, RP Center, though it's a tertiary care, it's a Apex Eye Care Institute, still we are also working in primary eye care, and we have started with 27 vision centers in Delhi and NCR region, where primary eye care services, refraction and other school vision screening program, all these activities are being provided. In fact, one initiative we have taken is screening for diabetic retinopathy, and that is being done by our optometrists. We use this non-mediatic fundus camera, and daily one screening camp for DR is being conducted for last 8 years now. And a lot of patients, diabetic patients who are having diabetic retinopathy, they are getting benefited under this program. Health education is integrated part of our vision center, also in RP Center. We have developed a lot of IEC material for the country, for WHO, for NPCB, and this is being used all over the country. Cataract is the leading cause of blindness in our country, and since 2001, we are having reach-in program under which screening camps are being conducted outside, and patients are brought here in RP Center for cataract surgery. In 1 year, we are able to provide service, free of cost services to around 3,000 patients. Every year, this is the special program for poor and needy patients, and they are not supposed to pay anything for cataract surgery under this program. In fact, for last 7 years, we have taken this initiative with the support of CBM. It is Disability Inclusive Eye Health Program, under which Professor Radhika Tandon and Dr. Suraj are taking lead for low vision services and rehabilitation services. And it's not only in RP Center, we are going to community, we have covered all the school for blind, and their children are being re-examined, given certificates. So all these activities are being conducted. And one special initiative was the certification for visually impaired. And in fact, this revised guidelines have been developed with the support of Ministry of Social Justice and Empowerment. And now even a lay person, if they know the best corrected visual acuity in their eyes, they are able to know the actual percentage of disability they are having. Previously, there were a lot of confusion were there, a lot of NGOs were requesting for this, but now with the help of this matrix, even a lay person can get the percentage disability you are having. I'm very happy to share that we led this National Blindness and Visual Impairment Survey, which was conducted with the support of NPCB and VI, and this report was released on 10th October 2019. And in fact, we also requested ministry and it was accepted. The definition of blindness was changed because of our advocacy. Now the blindness is defined as presenting visual acuity less than 3/60 in the better eye, which is same as the WHO definition. Previously we had a different definitions. I'm happy to share that we also conducted a national survey in 0 to 49 age group that was conducted in 2019, and nearly 18,000 people were covered in this survey. Beside this, we also led the National Diabetes and Diabetic Retinopathy Survey. It was conducted together with National Blindness Survey. And in fact, about these surveys, Dr. Suraj will be presenting how to conduct this survey in the next session. We also developed India Vision Atlas with the support of NPCB and VI. And in this Vision Atlas, data related to blindness survey, diabetic retinopathy survey, trachoma surveys, all is being incorporated. And any person can go to this website, that is www.indiavisionatlasnpcb.aims.edu, and can see the entire data in the form of maps and charts. In fact, among all, one of the biggest achievement for us is to conduct this national survey on human resource and infrastructure for eye care services. And under this survey, we are able to collect data from 8,000 institutes all over the country about the various facilities, services available in these institutes. And in fact, even this HR component have been incorporated in the India Vision Atlas. About trachoma, I'm very happy to say that in 2007, we first conducted trachoma rapid assessment survey. In 2010, we went to Andaman Nicobar and conducted survey there. The national survey was conducted from 2014 to 17. And based on this survey, Government of India declared trachoma disease, the children free of trachoma in our country. In fact, Dr. Nupur will be talking in detail about this trachoma services, trachoma surveys we conducted. In fact, now we are conducting trachoma survey in 200 districts. That is mainly trachomatous trichiasis survey, so that we can get certificate from WHO about trachoma elimination in the country. Then some epidemiological studies. I think the most important one is for last 10 years we are doing this UVR study, the effect of UV radiation on eye disease, and environmental study. Professor Radhika is leading this study. We conducted rural areas, urban areas. It's a multi-centric study. And in fact, we have gone to Leh, Ladakh and Sikkim to cover a component of this study also. And Dr. Nupur is here. She was the one who did PhD on epidemiological study on corneal opacities. Probably the first time this study was conducted. Dr. Rohit did PhD on myopia. And in fact, based on this study, we were able to give Ministry, Government of India, what is the actual burden of myopia among school children in our country. Again, one PhD study conducted in department is on childhood blindness and visual impairment. Dr. Meenakshi did study and covered 20,000 children 0 to 15 age group, and we identified the burden of prevalence of childhood blindness and visual impairment and also causes for this thing. Dr. Palvi is here. She did PhD on primary eye care involving ASHA workers, ASHA volunteers in strengthening primary eye care services in country. And in fact, based on this, recommendations were given to Government of India, and we have developed certain modules for ASHA worker under this program. In fact, we are WHO collaborative centers, and every year we submit report to WHO related to prevention of blindness activities. Lot of workshops have been conducted with the support of WHO, and recently we have developed a kind of survey methodology called rapid assessment of visual impairment survey methodology, in order to assess the effective cataract surgical coverage and effective refractive error coverage. These are the two latest indicators which have been given by WHO as an indicators for universal eye health coverage. Recently, we also did rapid assistive technology assessment, RATA surveys in 8 districts of India with the support of WHO. And a lot of work has been also been done in school for blind in our country. In fact, this is a Ravi survey. In fact, we have implemented this survey in Gurgaon, in Lakshadweep, and also in 2 districts of Odisha. In the last, I must mention that Vision 2020 Right to Sight program was started in 2004. RP Center is the founder member of Vision 2020 Right to Sight, and in fact, we are also looking forward to eliminate avoidable blindness in country by the year. Initially, the aim was by 2020. Now we are looking forward by 2030. Not only elimination of avoidable blindness, in fact, the recent indicators which have been given by WHO, we should have data and achievement in relation to achieving effective cataract surgical coverage and effective refractive error coverage for the country. Thank you very much. Thank you very much for
Sir, mic. Now I request Professor Dr. Surat Singh for his talk about the conducting rapid surveys in eye care. Sir.
Thank you, Sumit, Dr. Sumit. And what I was trying to say that, in fact, the scope of community ophthalmology is growing day by day, as Dr. Prevalence clearly highlights. So when I joined in 2012 in the community ophthalmology, and someone told me, so in community ophthalmology, the primary, eye care service screening is the only activity you are supposed to do. So why you join this department? And I said, no, I don't know. So what are there may be a lot of other activities as well. So now you realize when you see the presentation made by Dr. Prevalence, so there are other activities as well. Not this primary eye care service and school vision screening program. This is not the only one. So in that context, so the rapid survey in eye care is one of the very important activity in community eye care service and community ophthalmology. So other aspects like research and primary eye care service and research in terms of, say, community-based intervention in other association study. So there is another important area, but this rapid survey is one of the very, very important since the community ophthalmology department started in 1992. So now coming to the rapid survey, see, as you know that types of epidemiological studies. So you know that there are 2 different types of major types of epidemiological studies. One is descriptive, one is analytical. So when we say the survey, so this cross-sectional studies and population or ecological studies, these 2 subtypes of studies are surveys. So when you say survey and cross-sectional studies, of course there's a difference when you look into the diff. So this cross-sectional study is a scientifically term. Survey is a layperson. A layperson can use a survey. Because when you elaborate this survey, basically coming to the epidemiological language, so it is a cross-sectional study. So what is a cross-sectional study then? So it is one of the simplest types of epidemiological study. And here the information is collected from each subject at the same time. So the information you collect is about the outcome of the disease, exposure or both, and other factors like the confounding factors, other risk factors as well you can collect while doing a cross-sectional studies. So again, the types of cross-sectional studies, there are 2 different types of cross-sectional studies. So we say the descriptive and the analyticals. So descriptive is very simple. So you collect either exposure or outcome. You should not collect both. And whereas in analytical cross-sectional studies, so you have to collect both. Here you can collect the confounding factor and other risk factor as well. So apart from that outcome and exposure, so you have to collect other related variable as well. See, the example is cross-sectional studies, descriptive examples. So simple, what is the prevalence of blindness in India? So you collect only the blindness using some case definition. And second is, what is the prevalence of smoking among men? I say, what is the prevalence of spectacle wear in this house, in this room? Simple questions. So now coming to the analytical cross-sectional study. So here you have to collect other information as well. So say, for example, how many times men are more likely to be smoker than women. So you can compare here, spectacles were male and female here in this room itself. So example is here we need to estimate the prevalence ratio. It's very simple. What is the prevalence of smoking among men divided by what is the prevalence of smoking among women? Okay, so two different types of cross-sectional studies. One is a descriptive, one is analytical. See, again, so this is just an example. So genders, you have the exposure, male and female, smoking and no smoking. So the total N is 1,000. Okay, so what is the prevalence ratio here? So the prevalence ratio is smoking, okay, among male, prevalence of smoking among men, and prevalence of smoking among female. So you can, with that, you can estimate the prevalence ratio. But when the prevalence outcome is very rare, suppose here in the smoking, say so 30, it becomes 2. Then we don't use the prevalence ratio. We use the odds ratio here in a cross-sectional study. So many times, so you'll find, rather than estimating the prevalence ratio, you have to estimate the odds ratio. Okay, so remember, especially for our junior residents and the SR, so when the outcome is very rare, so we use the odds ratio instead of using prevalence ratio. Now, this is based on the resource availability. So we use, there are two different types of, again, operationally, to look the feasibility. So we use either ideal epidemiological study and rapid. So the ideal is very difficult for our country. Why difficult? It needs a lot of resource. See, in the other sides, so need more resource and time consuming. So for our country, it's very difficult to conduct ideal epidemiological studies. Why? So you have to use the simple random technique. So in the ideal technique and the ideal epidemiological study. So it's not possible for us. So you want to, if you ask, you make a list of sampling frame for 1.3 billion. Yeah, for in Delhi, there are 17 million. So you make a list of those 17 million, then you select randomly. It's not possible for us. That's why we go for a rapid survey, rapid assessment technique. So there are drawbacks, of course, in rapid assessment. So one is, it's not a representative, of course, because since we want to do a rapid technique, so we have to curtail, rather than using the all age group, so we have to see what is the maximum prevalence age group in that, using those area of, study, and then area of interest, I would say. So there is a not generalizable and less time consuming and need less resource, and it uses a simplified sampling methods. So we don't use very high-end, technique. So it is simple, and the examination also very simple, and you don't have to use those high-end equipments for doing a rapid assessment survey. So this is a type of rapid survey in eye health. RAF, you know pretty well about RAF, and the rapid assessment assistive technology. Dr. Basis highlight this data survey. And the other Ravi, rare, and Trachoma rapid assessment, and about the cataract surgical service. So there are the few comments, rapid survey technique, so we use in community ophthalmology. There's a few strengths about this rapid assessment. So it can generate quickly, the data. If any district or any state wants to design for planning purpose, so we can generate data very quickly. Okay, and then of course, once you have the data, so you can prioritize the districts. And then you also came to know that what are the most common problem in that particular area. So, and then this is the strength. That's why most of the time to plan very quickly for any program. So we prefer to use a rapid assessment technique. Very important points here. This may be very technical for other, for our junior residents and our senior residents. So I think you must know these sampling methods and sample size estimation and design effect. The three important terms while we thought of conducting a rapid survey. So the first is sampling methodology. Okay, so this is very important. There are three specific terms: target population, study population, and sample. So we should not make any confusion while defining these terms. What is target population, what is the study population, what is sampling units, and sample. Okay, so definition is a target population. In the RAP survey, the entire group about which we want information. Okay, the RAP target population is 50 years and above. What is the target population? Now coming to the study population. So we have the target population, Okay, and then study populations, so you'll choose one district. The group which you want to draw a sample, okay, individual age 50 years above from one district. So one chosen district can be chosen randomly as well. Your state can be chosen randomly as well. Okay, so this is study population. And from the study population, so you need to have a sampling units. That's individual with 50 years and above. Once you have individual units, then you can develop a sampling frame. So there's no confusion here. The target population is the entire districts, okay, the green area. From that, you have to select one block or sub-block as sub-district. Okay, there is a study population. From the study population, you have to choose the sampling units, and from the sampling units, and then sample will come. So these are two very important sampling methodology. One is a simple random sampling, one is a cluster sampling. The simple random sampling, as I said, is very difficult for us because we do not have that much of resource to do a simple random sampling. So we use the cluster random sampling. Then what is simple random? So you have list of sampling frame from 1, 2, 3, 4, 5 up to 12. This is the just hypothetical example. So okay, from there, so you have to select the sample randomly. Okay, so that's why the individual you are going to select could be from one place, and then the second one could be 10 kilometers away from the first one. The third one could be 30 kilometers from the second one. Okay, so that's why the simple random sampling is not feasible for us. That's why most of the time we recommend to use a cluster. The disadvantage I have already shown here. Okay, so the last, it is likely to be more practical to take a sample of cluster first. Okay, that's why the clusters economically, okay, operationally, okay, and everything is feasible to do a cluster random sampling. So now to the cluster random sampling, what is it? So you have a community here. So the community, you divide it into 6. The first, you see the square one, 1, 2, 3, 4, 5, 6. In a village, you have to divide into cluster. Cluster means a homogeneous group of people living in one area. Okay, so in the 6, this is the entire area. So you divide into 6 cluster here, cluster 1, 2, 3, 4, 5, 6. From this cluster, you select 2 cluster or 1 cluster according to your sample size. Just select it 1 or 2 or 3. Okay, so in that cluster, the disadvantage is once you select that cluster, because it is a homogeneous, means it's quite similar to each other. Either culturally, either socioeconomically, either, their habits is quite similar. That is the again drawback for us. We want more heterogeneity, okay, while doing a cluster random sampling. But when you select a cluster, okay, so it is more likely to be homogeneous population in a cluster. So there is the again disadvantage. That there will compensate by, some term we use, a design effect. To compensate that homogeneous effect, so we need to add one factor. That is called design effect. Because sampling design is a cluster random sampling. Because of design, there is some problem, okay, some error. So to compensate this, we need to increase the number of cluster. To increase the number of cluster, we have to multiply by design effect. So I'll come to the next slide. So this example, this is a list of villages, okay, 1, 2, 3, 4, 5, 6, up to 40 villages. Okay, so from here you can select either 20 cluster, okay, either 15 cluster, depending upon your requirement. This is just example, okay. Yeah, this is just example, Biznor, so we use the RAP survey. So these are in the Biznor districts, there are nearly 1,000, nearly 500 villages. So we select 50 clusters from this. Disadvantage, as I said, it is homogeneous. Okay, because of homogeneous, so we need to increase the sample size. When you increase the sample size, of course, number of clusters you are going to select will be increased. So here, because of this sample design, okay, so that sampling error, so we need to multiply by design effect. Okay, so in order to increase the sample size and further increase the number of cluster. Okay. This sample size estimations, I'm not going to in details. Okay. So now method of selection, so once you select a cluster, so coming to the households, how you select the households, okay. So household selections, we use 2 techniques. One is the EP random walk technique, the second one is a complex segment. So the EP random walk technique is very simple. So once you select a cluster, so you will go inside the center of the village, you choose randomly the first households. So here you can use either spinning a bottle or use some kind of seats. Suppose you will go inside the center of the village. Okay, so there will be household, front, left, right, pitch. Okay, there will be a household all around. So you just mark a household number 1, 2, 3, 4, 5. And you just pick up randomly one household. And once you choose that households, and then the second household you keep going. Otherwise, you spin a bottle, okay, once you go inside the center of the village, selected cluster, okay, and the opening of the bottles align with the household, you can select that household first. So there is a very simple technique that repeat in work. And the complex segment is you have to, again, divide the cluster into segment with equal population size, okay. Further, divide it into segment having equal population size. And you select one segment randomly. Okay, there is a complex segment. Once you select the segment randomly, you visit all the households situated in that segment. You visit all the households. So this is the segment we use. And RAF, as you know that we have conducted RAF very quickly. So these are the survey planning we use, preparation to conduct survey, budget and other things. These are some important. RAF, because it's a rapid, we call it 50 years and above. So we conduct the survey and we use the software to estimate the sample size and other things. So it is very simple. This is a RAF that we is already highlighted, and this is a finding very quickly. So 1.99% the prevalence of blindness above 50 years age group. When you extrapolate, it's a 0.36% in all age group. So the reduction in terms of prevalence of blindness from 2010 to 2019. And this is the cause of, the most common cause of blindness is uncorrected called cataract untreated. So I'm not going to details. And this is the, the prevalence of blindness and district-wise. Yeah. And the last two slides, this is the data, very quickly, last two slides. This is the assistive technology assessment. So here, the assistive technology for visual impairment is one of the very big component. When you say assistive product, so assistive product could be hearing, could be visual impairment, could be from locomotor. When you see the assistive product gamut, so assistive technology for visual impairment contributes around 50%. That's why we cannot ignore this assistive technology for visual impairment. So this data survey we conduct with support from WHO, and this is an initiative from WHO, and then UNCRPD, UNICEF, SDC. This is various initiative done. This is a tool we use, RATA, and this we have concluded RATA and submitted the data to WHO, and other further analysis and other things. WHO Geneva, they did it, and recently they have released the reports. And this is the aim. We need to estimate the unmet need of assistive technology in the village. Here, as I said, assistive technology for visual impairment is one of the very big components. And this is a district we could not cover because of time constraint. We covered 8 districts in the country. This is the workshop that we conducted for supervisors. Thank you.
Thank you so much. In fact, for last 20 years, this is a mandate now to conduct rapid assessment surveys, whether it is rapid assessment of avoidable blindness, which is like most of the studies nowadays being conducted, rapid assessment of trachoma, rapid assessment of refractive errors, and recently we developed a rapid assessment of visual impairment methodology. So the purpose is very clear. Because of time issues, we need to conduct survey fast so that they can give a right prevalence, true prevalence, and also the time consumption should not be there. Next, I'm going to invite Dr. Nupur Gupta. In fact, Dr. Nupur will be talking about the initiative on trachoma elimination in India. And Dr. Nupur is additional professor in RP Center in cornea unit. Dr. Nupur.
Thank you, sir. A very warm good morning. As we all know, trachoma is the leading infectious cause of blindness globally and also in India. And it's actually, I think, the only ophthalmic condition which has shown a very positive outcome over the years. So as we go by, India was supposed to be hyperendemic for trachoma in the 1950s and 60s, and actually the National Program for Control of Blindness was actually known as the Trachoma Control Program back then, and we had over 50% of active infection in children in the northwestern belt. So these states were used, is actually the endemic region of the country. In 1986-89, we saw a marked reduction, but still it did not, all the districts in all the states which were covered did not reach the elimination level, which is less than 5% of active infection in children aged 1 to 9 years. However, again, in the 21st century, we wanted to estimate the current burden of trachoma. A rapid assessment survey was again conducted, wherein some of the states like Haryana, Gujarat showed a decreased prevalence of active infection, but it was still quite high in Uttar Pradesh. This was not a prevalence survey, this was a rapid assessment survey. So just as we have all seen, prevalence survey is a random sampling, while rapid assessment is a purposive sampling. So rapid assessment is only undertaken when trachoma is thought to be a burden and we need to plan some public health interventions. It is not a true prevalence of the disease. So a national trachoma survey was envisaged by the National Program of Control of Blindness and Visual Impairment in 2014 and 2019 with 2014-2017 with RP Center providing the technical support to the survey. In this, we had actually covered all the northwestern belt with the prevalence survey and other districts where the active infection cases were reported from the district health administration or the state program officer. There a rapid assessment was conducted, and this entire survey actually covered around 88,000 people. So the results of the survey showed that active infection was way below the elimination threshold of WHO. It was 0.7%. It should be less than 5%. So we probably had eliminated active infection long time back, but we could prove it only then. However, so none of the survey districts reported more than 5% prevalence of active trachoma, and those results were then released by the then health minister, and India was proclaimed to be free of active trachoma infection. However, when the other criteria for WHO elimination of trachoma as a public health problem is requirement of TT unknown to the health system to less than 0.2% in adults aged more than 15 years. This was achieved by some of the districts. However, the districts that you can see in red, Bikaner, Tong, all those had an elimination TT prevalence of more than 0.2%. So we still had a burden of trachomatis trichiasis in the country. Just to put into perspective, trachomatis trichiasis, the contribution of trachoma to blindness is by corneal blindness, and trachomatis keratopathy still, this core study was done in around 13,000 population in 2010 to 2014, and it showed that trachomatis keratopathy still is an important contributor for corneal transplantation in this population. So the trachomatis trichiasis and the sequelae still is an important problem in the country. The journey of trachoma in the country can never be complete without the mention of Karnacobar Island. It is a tribal reserve island, the southernmost tip of the country, where you can only reach by ship or by an airplane or an helicopter. It is not open to civilians. There was a reporting of a lot of active trachoma cases from the state program officer in 2010, and this is what we found. So the clinical features that we saw there were actually not known. It was like an unknown territory we had gone. There were a lot of trachomatous follicles in the children with entropion, corneal opacities, even scarring in children, which is not known to this part of the country. So when the rapid assessment, we conducted all the 15 villages were covered, and we found an active infection of 50.8%, which was huge, and 10 per 1,000 burden of trachomatis trichiasis. So based on these findings, then we were wondering, because tsunami had just hit that island in 2004, and there were no the F&E components of the safe interventions. We saw the faces were clean. There was water which was near the households, but there was the possible risk factors we thought were actually overcrowding and their close contact with the animals. And this is at the down, you can see this is a typical Nicobari hut which had been changed because of after tsunami, the government officials had changed it, but still they were in very close contact with the animals. So we thought that was contributory. So for the first time in the country, mass drug administration was started with oral azithromycin in 2010, 11, and 12, and along with the effective implementation of STRAFE strategy and training and orientation of all stakeholders. So, and the Andaman Island was also covered in 2013 to see if there were prevalence, but we only found Nicobar to be the pocket. And a successful MDA was shown. This picture actually shows that in all the 3 years, MDA was administered with more than 80% coverage. The post-MDA survey findings showed, which was a prevalence survey, the active infection reduced to 6.6%. And the National Trachoma Survey, when the Nicobar Island was covered, the active infection was 1.6%. So active infection was actually eliminated post-MDA in the island. So as we are now, so what next? So an action plan was developed with a close collaboration with the WHO India office and WHO Geneva to reduce the national backlog of trachomatous trichiasis. A central task force and monitoring committee were formulated for policy planning and monitoring and reporting of trachoma cases from the states, and a training and sensitization workshop was conducted at the national levels involving the state program officers at the state level, district level, and the community level. So the initiatives that were planned were developed through 3 modules, which were important for training of the district ophthalmologists who will be conducting the trachoma surgeries and keeping the records, which is very important for developing the validation dossier, which would be submitted when India will be claimed trachoma-free by WHO, and the strengthening of FNE components was continued. An active surveillance from all districts, for which Dr. Pramila is with us, and she had initiated that part. And from all districts, all surveillance of trachoma cases was reported to the ministry. This is an important component, and along with a TT-only survey was planned in 200 districts of the country, which involves the northwestern belt, so it contains 8 states and 2 union territories where there were more trachoma infections based on the finding of the National Trachoma Survey. So this survey actually involves around covering 6 lakh population, 3,000 per district, and currently it was initiated by the WHO and Tropical Data team, training of trainers, and then 60 people involving health workers, recorders, and optometrists were trained, and it is currently undergoing. And the uniqueness of this survey was it is a totally mobile-based data collection, with data being uploaded as an active form, a GPS being recorded, and cleaning and verification of the data being done by the Tropical Data teams, international agencies, and WHO. Till now, we've covered around 1.5 lakh population and 48 districts. We had a mismatch of trachomatous trichiasis and active infections. So the WHO Geneva headquarters thought that maybe the trichiasis that we had picked up was both because of trachomatous and not trachomatous region. So we planned a study to actually see, it was conducted in RP Center, and both ethical clearance from RP Center, from AIIMS and WHO were undertaken. And being a collaborative study, we found that the trichiasis coming to the OPDs and our clinics was not solely due to trachoma. Only 1/3 was contributed by trachoma. The other causes were also important. So, these findings were then presented at WHO Geneva as part of the global scientific meeting on trachoma. And the WHO actually changed the definition based on the findings of this study, because we did not have any lower lid trichiasis due to trachoma. So the recommendation for trachomatous trichiasis was that involving only the upper lid. So since we have reached 2020, when GET 2020 was when we had global elimination of trachoma by 2020, then WHO came with the roadmap from 2021 to 2030, where a document was then developed so that all the neglected tropical diseases could be covered effectively and together. And so the roadmap is that we believe that with effective implementation, monitoring, and surveillance, we would be able to eliminate trachoma from India by 2023. Thank you.
Thank you, Dr. Nupur, for such comprehensive details about trachoma status and our elimination for trachoma in our country. In fact, with us we have Dr. Pramila Gupta. She's ex-DGHS, and currently she is advisor to Vision 2020 Right to Sight India. It is her initiative that we are at this stage. In fact, it seems a bit odd actually. Among the CRO countries at present, India is the only country where trachoma is not yet declared as eliminated. In 2018, even Nepal, they declared, they were given a certified by WHO as eliminated. In 2020, it was Myanmar. Now we are the only one. In fact, now we are very clear that whatever WHO, we have to understand what WHO needs actually, and they want survey, trichometastasis survey in 200 districts, which were previously hyperendemic in country. And it is initiative by Dr. Pramila. Yes, we will not only train team members, but will conduct survey in 200 districts. Responsibility has been given to RP Center, and I'm very happy to share, ma'am, that we have already covered 102 districts. And we hope to complete, even now at present the teams are there in Punjab and they are conducting surveys. And we are hoping that by the end of this year or maybe by March 2023, we'll complete this survey and we'll submit our dossier to WHO. Since WHO and Tropical Data Group are partner for this survey, we hope that we'll be able to declare trachoma, as Dr. Nupur has mentioned, by the year 2023. India will declare free of trachoma. Thank you, Dr. Nupur. In fact, for the last talk of this session, I would like to invite Dr. Pallavi Shukla, and she will be talking about primary eye care initiatives in form of vision center and community level, and initiative taken by RP Center. Dr. Pallavi.
Very good morning, all of you. And first and foremost, thank you very much, sir, for allowing me to present a talk in this session. I have been associated with community ophthalmology from 2015, and I did my PhD under the able guidance of Professor Vishisht. During my PhD, I had worked on strengthening primary eye care services for the urban vulnerable population of Delhi with the involvement of ASHA workers. So with my experience, I would be talking about the primary eye care situation in India with special focus on the government setup. Before we dive into it, what exactly is primary eye care? So as defined by our, as Sir has said, Professor Murthy, our father of community ophthalmology, it's a frontline activity for providing care and identifying disease before it becomes a serious medical issue. American Academy of Ophthalmology defines primary eye care as an appropriate, accessible, and affordable care that meets patients' eye care needs in a comprehensive and in a competent manner. It provides the first point of contact for eye care for the people. A good primary eye care program that includes equity, a community participation, intersectoral coordination, and sustainability. The plethora of services provided under primary eye care are, first and foremost, educating people about eye care, about the eye diseases, not only those which cause blindness and visual impairment, but also the common eye conditions. So that way, increasing the awareness and increasing the felt needs for the eye care. Then a comprehensive examination of the visual system, screening for eye diseases, recognizing the diseases early and ensuring a timely referral. Performing refractions and if possible, fitting and prescribing optical aids as well. Then coordinating with other physicians involved in patients' overall medical management. Because there are certain eye conditions which are also having certain systemic diseases which have an ocular manifestation and vice versa. So why exactly do we need primary eye care? If we look at the World Vision Report and the burden expressed in that, so everyone, if they live long enough, they will experience at least one eye condition in their lifetime. Now imagine the kind of burden that we have to deal with. At least 2.2 billion people are living with visual impairment, of which 1 billion are conditions which can be prevented or treated at the earliest. And we have also to deal with the inequities in the burden of eye condition with respect to gender, age, residence, and across nations as well. So the World Report on Vision, it has envisaged IPEC as the model of care, that is integrated people-centered eye care. With no more focus on disease-specific management, it should be like person should be first, and we follow the person across the continuum of care through the life course approach. That requires engaging and empowering people and the community so that they identify their problems first and then for the people and by the people. So reorienting the model of care based on strong primary eye care, and this needs coordination within and also across sectors. We need coordination with the education system, we need coordination with the environmental setup, and all those sectors which are working in a wider perspective. And also creating an enabling environment so as to have a sustainable service. Vision 2020 India has given this eye health infrastructure pyramidal model of care, wherein the bottommost tier was the establishment of a vision center per 50,000 population. This center would be manned by an ophthalmic assistant, and the identification of disease and referral system would be in place. Above them are the service centers which cater to a population of around 5 lakh, and here the basic ophthalmic surgeries are provided. Above them are the training centers per 5 million population, wherein we have medical colleges and regional institutes in place which provide higher ophthalmic management and surgeries. And topmost are the centers of excellence. So how far have we achieved these provisions? As was expected, the vision centers to be 20,000 by 2020. We just have barely 44,000 vision centers in place, including the private as well as the government setup. Service centers, as against 2,000, we have 4,000 service centers. And training centers, as against 200, we have 400. So the pyramid has become a little distorted. We need to focus more on providing these primary eye care services and through vision centers. So what exactly is a vision center? It's a fixed eye care facility in the community. It's the first point of interface between the eye care services and the community, provided by an exclusively skilled eye health worker and ophthalmic assistant, and he may be assisted by other field staff. This vision center needs to be linked down below with the community as well as high above with the higher centers. What is the purpose of these vision centers? So if imagine a situation where these vision centers are not there. So we have all very nicely placed service centers, training centers, centers of excellence, and even in your experience, you would have seen in your OPD, the kind of patients that reach to you, they are at a stage where sometimes you feel, why didn't they come to you earlier? So that link has to be established only when you provide primary eye care nearest to the population. So with the provision of these vision centers, we'll be able to triage cases more. The burden on the higher centers would be reduced. So more serious cases only will be referred to the higher centers. The lesser ones can be catered to at the primary level. Then linking to site-saving services, the time is a crucial factor. So if it is provided at the earliest, we can really save site. Then reducing the barriers and costs, because once the disease becomes more extensive, it would definitely require higher expertise and higher cost. Then improving the health-seeking behavior of the community by and large. Eye care is often neglected by people. Even when the primary health services are being sought of, primary eye care services are not being so much sought of because that health-seeking behavior towards eye services is lacking. Then ensuring gender equity. If you look at the male-female ratio of the people visiting the higher centers versus those visiting the primary centers, we find that at the primary levels, the females are visiting the centers more often compared to the higher centers which are visited by males more likely. So community engagement, till the time you do not form a link with the community, it's very difficult to pull them to utilize the services. So that engagement is definitely required. There are various models for primary eye care which have been developed. So either it could be through fixed centers, or it could also be through mobile units in areas where it is not easy to establish fixed centers and it is not that cost effective, where the population is placed sparsely and all those things are there. So there we have mobile vans and link them through tele-ophthalmology. Arvind Eye Care System is working on this model. Then we have through fixed vision centers, there are two kinds of vision centers. Either the standalone vision centers like we have with the LVPI, or the integrated vision centers, the way RPC has designed its model, wherein we are integrating our primary eye care services into the already existing government setup. So what are the services which are provided at Vision Center? Early identification and early management. Then first line management and referral of emergencies, that is very important because it could be sight saving in many cases. Provision of vision testing and refraction. Why do we expect a person to travel 50 kilometers for just having a prescription for a spectacle? And then, if possible, dispensing those spectacles in a door-to-door fashion. Referring and triaging individuals who require surgery, and then post-operative follow-up. There are institutes which are providing cataract surgeries by transporting patients across 140 kilometers, 200 kilometers. But will those patients be willing to have a follow-up as is required after cataract surgery, like traveling 140 kilometers? So that kind of service at least should be provided at the nearest possible facility. Then training of the local volunteers through telehealth and, if possible, even physical trainings. Now, Vision Center has been envisaged to provide a comprehensive care. So, taking care of all the levels of prevention, not alone the preventive and the promotive, the curative, as well as the rehabilitative and the follow-up. So, conducting an eye health awareness event, I'm sorry, in-clinic awareness also about how to have a better ocular health and how to really use an eye drop, what kind of post-operative care is required, and eye care training and orientation for health volunteers. Curative, the vision assessment, identification of common eye condition, and even, as Sir has told initially, the fundus imaging and identifying the stages of DR earlier. And another important role which can be taken up at Vision Center is keeping a track of visual impairment registry, which is at the moment lacking in our country. So rehabilitative and follow-up care through counseling and the post-operative thing, and even assisting people for availing a disability certification. These were few IEC materials developed at RP Center for distribution at these vision centers. These are the set of equipments which need to be available at the Vision Center: the trial set, trial frame, the vision testing drum, retinoscope, Snellen's chart, Chiard's tonometer, torch, lid speculum, epilation forceps, slit lamp, and near vision charts. So, the model on which RP Center is working is in partnership with some NGO for providing financial support and with the Delhi government. So here the already established primary health centers, there we had a word with the Delhi government agencies, and we could start our vision center facility once in a day basis, on a rotation basis. And this, the RPC team comprised of one optometrist who was assisted by 1 or 2 field workers depending upon the kind of burden that they were catering to. And there they provided the refraction facility, the early diagnosis and a referral to RP Center, then record maintenance and a daily reporting. Another important activity was involving the ASHA workers, conducting training programs for them so that the link is established between the Vision Center and the community. So at present we have 27 vision centers which are spread over 8 districts of Delhi and 2 vision centers in the neighboring state of Haryana as well. Some of them are supported by some NGOs, and few centers are located in the Delhi government dispensaries itself. So Vision 2020 model, it started from Vision Center to Centers of Excellence, but now we understand that a bottommost level has to be added, and that is the community level. So LVPI has a vision guardian posted at the bottommost level who links the community to their vision centers. Similarly, the government of India is also trying to build up on that model, and it's strengthening the primary eye care at 3 levels. First is the vision center level, which is at the population of 50,000. Sorry. The vision center is manned by a paramedical ophthalmic assistant But with the advancement of health and wellness centers, these are the new centers established under the Ayushman Bharat scheme. So for 5,000 population, one health and wellness center would be there, which will be handled by either an A&M or a mid-level health worker. So eye care services are also made a comprehensive part of this healthcare. And bottommost level is the community level. So primary level has to be provided at all these three levels. So at community levels, we have ASHA workers who are working for the population of 1,000 in the rural areas and 2,000 in the urban vulnerable segment. Then we have Anganwadi workers. We also have school teachers who assist in the primary eye care activities. It is estimated that around 1.5 lakh health and wellness centers will be established by Government of India by 2022. The operational guidelines for comprehensive primary health care has been done by the Task Force for Guidelines, and Sir and myself were also a part of this committee in formulating the guidelines for this. So what we have in place for health and wellness center is a vision testing facility, torchlight examination, and most important is the referrals and back referrals. Who's going to keep a check on where the patient has gone and what kind of care he received and how it has to be followed up. And the most important activity that has to be performed at health and wellness center level is recording the population and maintaining a record of visually impaired and number of blind people under health and wellness center. And last is the community level, wherein the already posted ASHA workers, who are the accredited social health activists, they will be engaged, they will be trained in providing these community-based primary eye care, wherein they'll be taught how to take a distance vision using Snellen's optotypes. They will make the community aware about the disease in order to increase the utilization of these facilities. They would remove the myths and misconceptions and make the people aware about the referral facilities. Then they are this link worker who will be linking up with the vision centers, the people, and following up of the patients. So these are the various volunteers who can be engaged at community level. It could be ASHAs, Anganwadi workers, school teachers, or any other community volunteers, the panchayats, NGO workers, health workers, and even the general practitioners. So the key recommendations so far are that establishing and scaling up of the vision centers per 50,000 population, dedicated human resource for eye care at these vision centers, and focus on cataract and refractive errors because these are the predominant causes of visual impairment and blindness. Establishing registry for blind patients, teleophthalmology and use of information technology, and yes, incentives for optometrists who are working in the remote areas. Opportunistic and planned screening. So once these blind registers and these things are in place, the need for these surveys could be not that much, it's a resource-intensive exercise, and we should really have these registries in place. So involving and incentivizing ASHAs in developing these registers and maintaining them, then promotion of IEC and the key messages and capacity building of the existing care providers. Thank you so much.
Thank you, Pallavi, for covering this topic so comprehensively. In fact, what we feel primary eye care is lacking in our country, and I expect all the students who are coming from medical college, they should try that. Such vision centers should be started in their hospitals. In fact, for RP center, what I feel is in 1 year we see nearly 6 lakh patient, and a large number of patients can be restricted to primary level if we have sufficient primary eye care services around any hospital. Thank you very much, Pallavi. In fact, our chief, Professor Tityal, is here. Sir, we welcome you, sir, and thank you very much, sir. In fact, this workshop is being conducted because of Sir's initiative, and it was his vision, please. It is his vision that first time we are conducting workshop on community ophthalmology and low vision. Thank you very much, sir. In fact, I request Meera Sharma to facilitate sir with planter. We have Dr. Pramila Gupta with us. She was looking after National Program for Control of Blindness and Visual Impairment for more than 5 years. In fact, she worked at the highest level in ministry as Director General Health Services, and currently she is advisor to Vision 2020 Right to Sight. I request Rohini to facilitate, ma'am. Professor Radhika Tandon, she is head of cornea services, she is head of low vision services, and also chairperson for this workshop. Simran, please, Westlit, ma'am. Yes, ma'am. Dr. Rajesh Hans, he is representing National Program for Control of Blindness, is Assistant Director General in National Program for Control of Blindness. I request Neelam to facilitate Dr. Rajesh. In fact, the President of Vision 2020 Right to Sight, Dr. Mohanty, is not well, so is not able to come. In his absence, Mr. Fanindra, who is CEO of Vision 2020 Right to Sight, he is representing here. And I request Priyanka to felicitate, sir. Yes. I request our Chief, Professor J.S. Tisyal, to give blessings to us and give welcome address.
Thank you, Praveen. Good morning to all of you. Indeed, it's a new beginning in such a beautiful day today in Delhi. After a long, hot summer, some respite for all of us. And I would like to welcome all the delegates who have come today physically in this center, and those people who have joined today online. There will be thousands of people joining us online also. And I'm delighted that we have Dr. Pramila Gupta. She's been with us for a very, very long time, always helping us in all aspects of not only the healthcare related problem, for other things also. She's been always there, and thank you, ma'am, being with us for such a positive manner for last so many years. And I'd definitely like to again welcome you to this center. Like to hear from you the new directions for all of us. And people who have come all the way from different parts of the country, because their being here makes huge difference. Because I know that as Dr. Praveen nicely elaborated, the entire journey of our section of community ophtha for last so many years. In fact, as he told, this is the 30th year of beginning of that particular unit or a section of community ophthalmology in the epicenter. And remember my dear friend Dr. G.B.S. Murthy, who was the first faculty in the department. He's there, joined us today, and welcome you, G.B.S., for being with us. And I remember my days with him. All began when I was an intern in Deliverables, and he was there, and he saved my day that day. My first posting as an intern was in Deliverables, and they posted me in the indoor ward duty, 9 a.m. to 9 p.m. And I had no idea what is to be done there. And he saved that day for me, because there were kids coming from we call Chhatri, the pediatric department, OPD. I had no idea what is to be given to them. Thank you, GBS, for helping me for that particular day. And since that day, we have been a very close friend and associate. And I remember till date, one of my first peer-reviewed publication was done by Murthy only. Thank you again for that. And I remember days where we talk about community as a subject. It is given to you. is inculcated to your system as you join medical education. Right from the MBBS days, I remember my days as a first-year student in MBBS, you are posted in a village areas. You are taken by your PSM department where they give you access to those families, those society, gives you a sort of a culture to begin with that you are not only meant for education, you are there to support the entire society of a country in terms of giving the health care, education, and various survey which can be done through them, and various assessment can be done through them, and give them a actually comprehensive relationship of the physical, the manpower which we procure, which we make from this country's process, which may be physicians, which may be surgeons, which may be optometrists, which may be health workers, field assistants, and we talk about now ASHA workers. They are a system which is going to help the community, the society. We all know this is a part of our entire medical education and the medical part of executing the treatment to the society. Looking back into the RP Center journey in community ophthalmology relation things, we had a reach out program to begin with. The first survey, as Dr. Parveen talked about the journey, started way back in 1973 when ICMR supported this survey of national blindness in our country, 73, 75. And from there, the NPCB started this blindness program. And there we had 80 mobile units for the country. RP Center was the apex institute to look into this NPCB blindness program. And it went on for a very long time. Unfortunately, health is a state segment. State has to look after the various aspects of health. And as the last slide of our last presentation talked about, we have to improve the primary health care. How do we improve that? As we discussed, need to establish the grassroots level treatment which consists of a basic diagnosis of disease, basic investigation if possible, and giving the treatment which is possible at that particular juncture or area, and most importantly, refer them to a proper area for a proper care. And to establish this primary care units, the entire country has to be supported by all these states, union territories, to build up this infrastructure, which is going to be a massive work. If you take the example of Andhra Pradesh, North Telangana, where L.B. Prasad had done a wonderful work. In the southern areas, there are various other centers which are doing a good community work. The same thing has to be translated across the country so that we develop this aspect of giving primary care to our people, which is the basic requirement of every individual to get a primary treatment at doorstep. Second aspect of, as we talk about workshops being done in RP Center, is not today or last 5 years we are doing workshops. It has been there since the inception of RP Center. The workshop were there. And those days, it was for 2 weeks. People had to come for 2 weeks to stay in the RP Center and learn the particular subspecialty, which was, like suppose, let's talk about the strabismus. People used to be selected and they used to come and be there for 2 weeks and learn everything. Because those days you had no access of a learning apart from going to a particular institution, which was difficult. So these workshops gave access to people to come and learn, see the department, and improve their own department subsequently, and give the younger generation some sort of incentive to bring something forward for them also. But fortunately, from beginning of early 70s or late 60s, things have changed so much. Now you have access to everything. Today you want to see something, you click YouTube and you have access to everything. But despite that, we have shifted to modern day techniques of improving teaching and transmitting the knowledge to other person, mainly because of access which can be given, especially in the COVID time. We have realized that in fact you can approach more people at a given time with online systems. Today we will be having more than thousands of people connected to us, which is impossible in our physical meetings. So that's one good thing which has happened in COVID time in terms of learning and creating resource-wise as such. Second important thing is the which we talk about giving a good survey for the country, which we know that apart from the survey which has happened, the recent survey which Praveen talked about, 2019 release, where cataract is a significant part of our blindness still in the country. And Dr. Indu is going to talk about that, how they are going to initiate a new program to take away the backlog which has now increased so much in the COVID time. Despite pre-COVID, the country was doing almost 50 to 60 lakh surgery in a year. And despite that, we still have the largest segment of blindness because of cataract. And that is, I personally feel, because we are not targeting the actual resources to those areas where actual blindness with cataract is there. Cities like Delhi or metro cities, we are operating people with a 6/9, 6/6 vision also. And that per se also increasing the backlog for those people who are less than 3/60. So if you just see the entire strength of manpower we have to tackle all related category-related problems, I'm not talking about blindness, then it's a massive task for the country to take away the entire load of people suffering cataract-related vision problems. Blindness is a separate thing which requires a separate force to tackle. There's a huge segment. And second important thing is a corneal blindness or corneal opacity, which has become a large area for a concern for us. And that because one important thing is we have to look for those cases where we can actually treat them to improve their visual quality and maybe a life subsequently by giving a transplantation, which is a massive challenge to us. Second aspect is, which Praveen talked about towards the end, is avoidable blindness. I think that is a major shift of our entire thinking tank, right from the government of India to various NGOs and institutions, to look into a preventable or avoidable blindness in future. All resources will be directed to that area. In that, I think one of the most important aspects is pediatric blindness. In that, refractive error is the most common thing. We have to look into that area. Control of myopia is a very important area for us. Apart from that, looking for the other iatrogenic blindness, which is so common in the country, which you all know is a trauma-related blindness in the country, which may be just a corneal trauma, which can be an intraocular trauma. It is the largest cause of corneal opacity apart from the infection in our country. So you see, so many things are there which has to be a part of not only for a clinical aspect, for a social and a community level also. The other important area for this workshop is low vision aids. We are talking of low vision aids, which is an important segment of management in ophthalmic care. If you can bring a blind category patient to low vision, that's a huge achievement. If you are a patient who is a low vision category, if you can brought to a normal vision, that's a huge achievement without doing a surgical or doing an optical correction of that person. So there is a huge, I think, we have to work on improving our low vision assessment areas, the clinics, the teaching, the large optometric students which have come today, they have to learn the technique of assessment of these patients and give a low vision aid services to these patients. Because rehabilitation is going to be the most important part. As you saw the last 2-3 days back, it was a newspaper that our life expectancy has increased significantly. Now it is almost 70 years. If you look at 1947, it was, I think, 47 years. So see the change. And that also puts pressure onto the healthcare system also. You're going to have older patients. Like we used to say, we have a largest younger patient population in the world, which is not going to be true in the next 10 years. We'll have a larger group of older patients also. So who's going to take care of those people? So you people have to look into those areas also, create a low vision areas. Make in India program will be very significant component in this because low vision aid systems are very, very costly. If Indian companies can come forward, they procure, they make these things, that will make easier for us to look into some sort of assistive technology which can improve the blindness people to work. We know that there are blind people who have created history because they could go through the hurdles of what they had. So why not to support these people and bring them to the forefront of our country's workforce, and improve the lifestyle of our people. The entire generation of population will change and India will be better. I would again like to thank the faculty of RP Center, especially the committee of the department, which is headed by Praveen Basis now, who is also a Vice President to Vision 2020, representing the RP Center. And Dr. Radhika Tandon, you all know, she is the head of a cornea refractive segment, looks after the entire low vision services, which is the center of national importance in the RP Center. They've done a lot of work. And I hope that in future this will expand to our entire country so that we have two important aspects: teaching people from various segments of our country who are giving health services, and reaching out to them in a peripheral area also where patients are actually living. So these are our motive to have this workshop for a younger generation. I know that you people are akin to a retina, cornea, glaucoma, but this is also a very important area, and important because it has to be there as a part of our services. If you look into a social service through your clinical approach and your sympathetic approach, the things will be much better. We all know doctors can be better than a human being just because of their attitude towards the patient. If you have a sympathetic attitude, you become a better doctor without touching the patient. So that should be our attitude. Wish you all the best and have a blast. Go through all the aspects, because most people read these things towards the end of their, you can say towards before the examination. But this has to be part of your system. Make sure you live with this and make sure the life of yours and the people suffering from blindness also improve. Thank you again and welcome.
Thank you so much, sir. In fact, sir is so connected to community that we feel so happy and delighted that under his able leadership, we wish to achieve whatever sir want from us. Sir, in near future, we're looking forward for National Corneal Opacity, Corneal Blindness Survey. We're looking for a school vision screening program in a big way with the support of Orbis, and with CBM, a mega project in which we'll be training other institutes, other AIMS and RIOs in low vision services, also in strengthening primary eye care services, sir. Thank you very much, sir. Thank you. In fact, with us we have Dr. Indu Grewal also. I request Meera to please felicitate Dr. Indu Grewal. Dr. Indu currently leading in ministry and managing the National Program for Control of Blindness. Dr. Indu. In fact, during my presentation, I myself restricted work mainly which was done after 2011 or 12, because we know that we have one person with us, Professor GVS Murthy, who initiated this section of Community Ophthalmology way back in 1992. And as Dr. Titiala has mentioned, we are celebrating 30th year of Community Ophthalmology in RP Center. Professor GVS Murthy he was colleague with us, he was my teacher also, he was my guide in ICH, and I think each and everything. Today morning I mentioned that if I have to name one person as father of community ophthalmology, it is Professor GVS Murthy actually. So I request sir to please bless us, to motivate us, and also briefly tell us about the activities from 1992 to 2010 till the time sir was leading here in community ophthalmology. Sir is currently director of IIPH Hyderabad and also professor in ICH London. Dr. G.S. Murthy sir, welcome sir.
Thank you, Praveen. I hope I'm audible. It's actually a momentous event. And Dr. Titial mentioned about the internship experience, but more important than that, our experience in Saharanpur. I used to go for the eye camps conducted by the Lions hospitals in Saharanpur. He was the most popular surgeon across the whole of UP. Everybody wanted Dr. Titial to be there. And he used to have, like he just mentioned, have a blast. We used to have a blast when we were in Saharanpur. And that is where we started also doing work on industrial ocular morbidity. It's one of the research components So, thank you, Dr. Titial, because it's always wonderful to be reminded of those nostalgic memories. So, thank you very much for that. So, Praveen, I'm sure you would have talked about part of the journey, but 1992, we changed from mobile ophthalmic unit to a community ophthalmology section was facilitated by the management at RP Center, and those days, Iec Activities was the chief. Just following on the 86, 89 survey, though we all look at that as a watershed moment for eye care in general, for RP Center it was a watershed moment because that led to the conceptualization of having a separate community ophthalmology section. In terms of service delivery, the mobile ophthalmic unit was doing wonderful work, doing cans right across, like Dr. Titial mentioned, the reach out approach. And they were traveling to so many locations, the demands were high, and the visual outcomes were excellent. And that's why RP Center's outreach programs were so popular. 1992 added a new dimension. And that dimension was that not just the service delivery, but there is a need to also look at evidence being generated, creating that evidence base for better implementation of programs. Right from 1992, when I joined there as the first person at Community Ophthalmology section, we have been looking at increasing the impact of evidence on service delivery. And I think that was, again, a watershed moment. For Dr. Praveen's information, the first ever community ophthalmology workshop was also conducted in 1992 here at RP Center. So 30 years ago and 30 years later, the legacy that has been set is being followed, and that's again a great achievement. I wasn't there in 1992 when the Community Ophthalmology Workshop was organized. It was Dr. S.P. Garg and Dr. Dinesh Talwar, under Dr. Khosla's guidance, who had conducted that WHO-supported Community Ophthalmology Workshop. But like Dr. Titial said, that was a long duration workshop, from which we have now moved away to much shorter periods. So 1992, therefore, is a new journey. So it's basically that the work has increased. I remember starting off with 2 rooms for the mobile ophthalmic unit and sharing the rooms across 10 staff members. And that changed significantly. The trajectory changed in 1996 when Professor Dada took over as the chief of RP Center. I think that again is something very important. Community ophthalmology would not ever reach the heights that it reached today if it is not for the support that comes from the chiefs of RP Center. And which is why when Dr. Praveen mentioned looking forward to Dr. Titial leading the activities of community ophthalmology and furthering the course of action, it is very critical. Because unless the chief provides that macro environment for different disciplines to grow, it becomes very difficult. And that in 1996, when Professor Dada took over, was a game changer, not only for community ophthalmology, the excellent lab infrastructure, the wet lab, one of the first wet labs in the country came up at RP Center, and state-of-the-art labs being set up. Again, it's a tribute to the leadership abilities of Dr. Dada, which allowed that to happen. And then, of course, there have been excellent chiefs who followed later, who consolidated the inputs provided by the earlier chiefs, and that is where community ophthalmology is where it is today. There are two things that we must remember. Earlier, service delivery was there. It was ophthalmology-led service delivery. 1992 changed that a bit to bring in extra skill to strengthen RP Center. And then 1993, Dr. Sanjeev Gupta joined, adding more weight to the delivery of research over there. And finally, when Dr. Praveen Vashist joined, it became a complete unit which could now be looked at more as a department rather than a unit. And I would request Dr. Titial to give consideration to that, because the three people now who are there at community ophthalmology, Dr. Praveen Vashist is more of the public health policy perspective and epidemiology. You have Suraj, who looks after rehabilitation, assisted devices, low vision, again an important dimension, and Vivek, who brings in the IT into the X. He has excellent skills in epidemiology, public health, and information technology, and with different domains now being inculcated there into the fabric of the community ophthalmology section, it is the right time to make it a department. Finally, before I end, I'd like all of you to remember one thing. The movement from a community medicine department to subspecialties started with obstetrics and gynecology, pediatrics, before it came in at RP Center in community ophthalmology. But the difference was that the departments of social pediatrics, social obstetrics withered away over time because the leadership did not support it. Community ophthalmology as a distinct specialty has grown and grown with time. And that is because of the leadership support, the governance structure which has been set up. And therefore, community ophthalmology today is an example to other specialties like cardiovascular diseases, oncology, all the chronic conditions, non-communicable, long-standing conditions, just like the example of community ophthalmology as a case study can be followed by so many other departments, specifically mentioning cardiovascular diseases as well as oncology, but neurology is there, where also the same thing can actually make a difference. So you learn from this example, show the passion, and that is the difference. Why community ophthalmology has grown to the stage it has grown is the passion, the dedication, and the sincerity above everything else. Personal work was set aside, institutional work gained prominence. And that is what Dr. Praveen is also continuing. I'm sure with support from Dr. Titial and Dr. Radhika, community ophthalmology will grow even further and become a case study for other disciplines. Thank you very much for giving me this opportunity.
Thank you so much, sir, for blessings and guidance, sir. In fact, sir knows us so well because all of us, me, Suraj and Vivek, though he left RP Center in 2010, but we are a student as in ICH and he's been constant source of guidance for us. We'll try to go as per your suggestions, sir. Thank you very much, sir. Thank you. Now I request Dr. Promila Gupta, she is chief guest for the session. Ma'am, please say a few words, ma'am, please.
Thank you. Very good morning to all of you. It is really a pleasurable moment for me to attend this workshop And thanks to Dr. Titialo, who started this monthly workshops, including community ophthalmology in it. And I hope all the medical students and the ophthalmic postgraduates would learn a lot from it. And since it's being webcast, it will be a good learning experience for all the community ophthalmologists all over the country. Secondly, I think this is a good this thing for integration of the ministry's NPCB program and the Apex Center of Ophthalmology, that is RP Center, as well as the NGO's representation, the Vision 2020 Right to Sight, which is a consortium of all NGOs. And this is very important in any community ophthalmology program. As we know, in ophthalmology, NGOs have played a great role since the very beginning. And even in our National Program for Control of Blindness and Visual Impairment, we have given importance to NGOs since the very beginning. They contribute to around 70% of our community ophthalmology work, like cataract, refractive error, and even the community, the primary eye care centers. Around 60 to 70% of work is done by NGOs. So this will be like a collaborative effort. We'll be able to exchange ideas, and I think the community will be the maximum gainer out of it. So best of luck and happy learning. Thank you.
Thank you so much, ma'am. And I'm very happy to share that madam is still active and she is part of Vision 2020 Right to Sight program as an advisor, ma'am. Thank you, ma'am. In the last, I would like to request Professor Radhika Tandon in fact, she is the one who conceptualized this workshop. And I request madam to say a few words and also thanks Chief Sir.
Good morning, respected delegates and faculty and honorable chief guest. So much has been said, and I'm sure you are all feeling very inspired to hear the journey of how this field has developed at RP Center. And in fact, one would like to remember it was Dr. L.P. Agarwal, who was the founder for RP Center, who had the vision way back to make sure that we have this national program for control of blindness, started as a trachoma control program. And this was the first blindness control program all over the world, whether it was like a public health initiative. So that is how it started. And I'm very grateful to Dr. Titial. He is always very supportive for everything that has to be done. He's never refused to give any support for any activity that is required, and he's always encouraging everybody to strive to do well. Just two more words that all this information that you're getting, sometimes, different people look at it from a different perspective. But if you look at some of the data, you would see that a large, like from Nupur's data, she had shown that a large percentage of people who required corneal transplantation actually had complications of cataract surgery. And cataract is the largest cause of blindness as far as, surgical intervention concerned. So it's very important that every ophthalmologist has that responsibility to do good cataract surgery, because one should not forget all these things by expanding our scope, but doing a good cataract surgery and giving good vision to the patient is, of course, very good, and everything that you do for that is important. And of course, there's no end to the number of people who are helping. All the people going on the surveys, if they don't do their work seriously, they do not collect the data correctly, then everything we are looking at is maybe nonsense. So we're very grateful to all the people who follow those hardships. They go to the remote areas, they are living from their comfort zone. Even during COVID pandemic, they went. And there's so many good leaders among us. That's the other thing which we should feel very encouraged. India is actually a great country. Even when you go to the community, you find people are living their lives and they're struggling or they're, contributing in some way. And plus we have all the people who go on these surveys who are so capable, and you'll see leaders will coming up from every field. So I would just encourage everybody to stay motivated, and many thanks to Sir, Dr. Titial, Dr. Pramila Gupta, Dr. Indu Grewal, Dr. Rajesh Hans for having taken their precious time, come here today and participated and sort of motivated everybody for this important activity. Thank you.
Thank you, ma'am. I think now we can start with our second session. I request the chairs to be on the dais, please. For Professor Tityal, sir, and Dr. Pramila, ma'am, and Dr. Indu. I think I'll be first talking about the finding of National Blindness and Visual Impairment Survey. In fact, we are thankful to Ministry of Health and Family Welfare for sponsoring this national survey to us. The survey was started way back in 2015 and we completed in 2019. It was probably the biggest ever survey which was conducted in 31 districts all over the country. And we examined 93,000 population, 50 plus age group, 50 years and above age group. And you can see all the districts which were covered. It is comprehensively representing the entire country. In fact, the definition of blindness in this survey was modified and it was visual acuity less than 3/60 in the better eye with available correction, and visual impairment was taken visual acuity less than 6/18 in the better eye. Just remember, even blindness was taken as component of visual impairment in the definition. And as per if I share the findings, the prevalence of blindness among 50 plus population was 1.99%, whereas overall prevalence of visual impairment was 13.76%. And just in comparison between previous surveys, 2001 National Blindness Survey was conducted by NPCB. In 2007 it was a RAB survey, and now 2019. You can see the prevalence of blindness is significantly reduced. In 2001 it was 5.3% 50 plus population, 2007 it was 3.6%, and now it is 1.99%. But one thing which I would like to mention here is that if we compare the gender, males and females, whether it is blindness or any kind of visual impairment, it is higher among women. So it is need that we need to work on this area and provide more and more services to the women population. As far as age group is concerned, we all know that blindness is age-related phenomena, and you can see in 50 to 59 it was just 0.5%, whereas in 80 plus age group, the blindness was 11.6%. Another thing to emphasize here that blindness is much higher in rural population compared to urban, and also it is much higher among illiterate compared to literate population. And this is the scenario, the overall view of all the districts that were covered. Average was 1.99%, and it was ranging from 1.08% in Kerala, Thrissur to 3.67% in UP Bijnor. And if we see the causes of blindness, still as Dr. Tityal has already mentioned, the cataract is the still leading cause of blindness, responsible for 66% of blindness. The second cause which has emerged is the non-trichomatous corneal opacity, which is responsible for 7.4. In fact, the trichomatous corneal opacity is reduced significantly to just 0.8% now. So, and a third leading cause, it is very important to say that the cataract surgical complications, which has emerged as a third leading cause. But I'm happy to say that if we compare refractive error, which was second leading cause in 2001 survey, now it is just responsible for 0.1% of blindness. This may be due to change in definition of this thing. Another aspect, diabetic retinopathy, we thought that DR may be an important cause of blindness, but as per this survey, DR is still responsible for just 1.2% of blindness. As you can see, when we talk about avoidable blindness, still nearly 93% of blindness is avoidable, 93%, another 96% of visual impairment is avoidable. That means there is still scope of working and achieving blindness to a much lower level if we really work on avoidable blindness. We also conducted survey in 0 to 49 age group so that we can actually estimate the prevalence of blindness in overall population. And you can see among 0 to 49, it is not trachoma, it is not cataract, it is the corneal blindness, which is responsible for 37% of blindness, that is non-trichomatous corneal opacity. Then we assess the prevalence in overall population. The overall population prevalence of blindness is 0.36%, whereas prevalence of visual impairment, in the second last row, it is 2.55%. So In fact, this WHO and in fact India was a part of that program where it was Universal Eye Health Global Action Plan 2014 to 19, and under that program it was aimed at will reduce the prevalence of visual impairment, avoidable visual impairment by 25%, taking a baseline of 2010 and the target was till 2019. And I'm very happy to say this figure that in 2010, WHO estimate the prevalence of visual impairment for India was 5.3%. And as per this survey, we achieved to 2.55%. So it is actually 51.9% reduction compared to a target of 25%. It's a big achievement for our country. And beside this, the blindness prevalence, it was estimated as 0.68%, and we have achieved 0.36%. Again, a big achievement, nearly 47% reduction. This is the scenario for the entire country. First survey was 1971 to 74. At that time, the prevalence was 1.38%, and that is as per the 6/60 cutoff, not 3/60 cutoff. And at that time, National Program for Control of Blindness was started, and you can see now it is 0.36%, and we had a goal of achieving to 0.3%. So we are almost quite near to our goal. Now the current goal by under the National Health Policy is to reduce it to 0.25% by the year 2025. Again, National Diabetes and Diabetic Retinopathy survey was conducted. It was conducted in 21 districts out of 31. 63,000 people were covered in 50 plus age group. And as per this survey, we did fundus examination of all 50 plus age group who were identified as diabetic or non-diabetic or new diabetic. The total prevalence of diabetes was 11.9%. 2/3 were non-diabetic, 1/3 were new diabetic. And among the diabetics, the prevalence of diabetic retinopathy was 16.9%. And I would like to emphasize on sight-threatening DR, it was 3.6%. So it was significant burden of DR is there among diabetics, though it is not an important cause of blindness in our country at this stage. One thing I would like to emphasize here is that more than 90% patient, they are, 89.9, nearly 90% patients, they have never gone for eye examination, 90% of diabetics. So just 10% patient going for diabetes, for retina examination is the current scenario. You can understand what is the need of awareness and what is the need of providing services in the community. And if you see this in overall scenario, you can see that the prevalence of diabetes and DR is much higher in southern India compared to northern part of the India. And in fact, based on this national survey, we have given some estimates of cataract. The cataract is the leading cause of blindness. What is the need for cataract surgery in our country? So we use this data, entire data, which was of the survey data. And finally, we are here to say because patient need to be operated in both eyes. So though overall number of visual impaired patients are nearly 33 million, but need for cataract surgery in our country, this is a backlog, is nearly 40 million patients. So this is the current burden, and in fact we expected ministry that some special program need to be started in our country in relation to cataract backlog elimination. And for this, thank you very much. For this discussion about what we need to do, we have with us a team from ministry led by Dr. Indu Grewal and Dr. Rajesh Hans. And first I would like to invite Dr. Rajesh Hans. He'll be talking about brief about National Program for Control of Blindness and Visual Impairment and the key program strategies at this stage. Dr. Rajesh.
I was just trying to get the pointer and it seems it's not there. So we'll start with the presentation. Respected Chief RP Center, Dr. Titial sir, and the chair, my colleagues and friends. Today I'll be presenting NPCB-VI program strategies. And I'm working as Assistant Director General at the Ministry. So I'm happy that many speakers have already given you quite a clear impression Okay. So already a lot of important talk has been done regarding the start and the progress of the program. I'll once more summarize. It was 1963, which was the moment when it was started as Trachoma Control Program. It was merged under NPCB in 1976. Initially, it was 100% centrally sponsored scheme, and from the 12th financial year onwards, it was 60-40 scheme for states and 90-10 scheme for hilly states, J&K and Northeast states. This 60-40 and 90-10 is the financial breakup. The nomenclature of the program was further changed from National Program for Control of Blindness to National Program for Control of Blindness and Visual Impairment in 2017. And the cause was, as stated previously, 3/60, which was incorporated in the program. We had a goal to reduce the prevalence of blindness to 0.25% by 2025, which presently is 0.36 as per RAB survey. Other objectives: to reduce the backlog of blindness, to develop comprehensive eye care facilities at all levels, PHC, CHCs, district hospitals, etc., etc. Develop human resources for providing eye care services. Improve the quality of service as stated by Professor Radhika. Quality is very important. And secure the participation of voluntary organization as stated by Dr. Gupta. And of course, to enhance the community awareness of eye care. All these diagrams are oft presented. Once more, I'll like to say that in 1976, the prevalence was 1.4%, reduced to 0.36% in 2015-19. This is the pie chart which shows the causes of blindness in more than 50 years of age group people, cataract being the leading cause, and then, of course, the highlighted one is the cataract surgical complications of 7.2%. Let's come over to what are the strategies that we follow. So we have the strategy of having a central division at the level of ministry, which collaborates with central and state NHM framework. The technical input is given by us, that is the DGHS people, and the budgetary demands of the states are seen by us during their PIP estimates, and it is further recommended by us. Important step here is to have key deliverables, because these are the various factors which we use to determine the action taken at the level of states. We give the grant in aid for distribution of spectacles and cataract surgeries, which is performed by government, NGOs, private practitioners, and we give the technical recommendations for giving the financial assistance for this. Not only that, we give grant in aid for infrastructural upgradation of eye ward, OT as per norms, grant in aid for purchase and maintenance of various equipment as per norms. Manpower development is also given by us. The Iec activity, these are all important strategies. So Iec activity is one of them, is supported by NHM program. It is also evaluated technically, and the suggestions are given by us. Importantly, social media, which is being used today also as well, is increasingly used for solving individual problems and delivering useful messages pertaining to NPCB-VI. So that is what we have been doing with the present program. We don't stop there. We have other improvements and modifications with the time. One of the important thing is to have this Vision 2047, which is still at works. It's not final yet, but giving you an initial peek at it. Elimination of blindness from India till 2047 by providing all Indian citizens comprehensive eye care at their doorsteps through NPCB-VI, and to declare India as blindness free by 2047. A lofty goal, but I think we can achieve it. A reduction in backlog of blindness by 100% through identification of and treatment of blind by 2047. Development of comprehensive eye care facilities at all levels, PHC, CHC, district, hospitals, medical colleges, RIOs, etc. Participation of voluntary organizations, improvement in quality, which has to be there always, and enhancement of community awareness. So I think next speaker, Dr. Indu, would be speaking on this, to declare India as cataract backlog free, blindness free country by 2025. We have been talking about blindness and this and that, but nobody talks about the problems faced by the earning age group people, and uveitis is the commonest affection in that age group. So we have some sort of plan, initial plan to start uveitis survey at national level. We have to add large private sector ophthalmology institutions which are well known, which are those as regional institutes of ophthalmology. Till now the policy is only to add governmental organizations. We have to increase the focus on other causes of visual impairment apart from cataract, which is being done as a rudimentary initial step till now. And to advise for all this, we have to have high-level scientific committee to help the government proceed with the aims and objectives. There are various types of ophthalmologists. So one category is CHFs, ophthalmologists. They are neglected. So we plan to have them incorporated in the program so that they coordinate and report all the activities at state level and coordinate with the ministry. A lot of talk has been given to mobile care units, but we have to have comprehensive eye care mobile unit vans, which would be the basic ones, and advanced eye care mobile vans, which would be giving quality-free advanced diagnostic therapeutic services at district levels by 2032. And we have to focus on the visual impairment of 0 to 18 years old with collaboration of RBSK. If we talk of the states and the ground level surgeries, we still have an idea that SICS is being performed in the major surgeries. But then we have to have phacoemulsification. Things are changes, of course, at ground level. So we plan to have phacoemulsification cataract surgeries and foldable IOLs in all the OTs throughout India, collaborate with RBSK, NCD clinics, social justice department for low vision aids, which is the gist of today's meeting. And to implement implantation of xenografts, artificial corneas, artificial bionic eyes as per recommendations of high-level scientific committee mentioned before, and NOTO through NPCB-VI by 2047. These are various steps in the roadmap that we devised. And once more, the summary of programs and services that we provide: free cataract surgery, school eye screening, free spectacles, collection of donated eyes, free keratoplasty, diagnosis and treatment of diabetic retinopathy, squint, glaucoma, etc. Infrastructural upgradation, very important. Training of eye surgeons, very important. And PMOAs, support of new eye banks, and OT construction. IEC, very important part of the whole process. Monitoring, surveillance, and review. So I have told you right in the beginning that there is a team in the center. We have got two part of that team, that is administrative division, which is part of the ministry, and technical division, which is part of the DGHS. Similarly, at district, sub-district level, we have got various functionaries such as budget finance officers, administrative assistant, MTS, and data entry operator. For district hospital only, we have got ophthalmologist and other staff, which is thought appropriate by NPCB-VI is deputed there. We keep on giving recurring grants for various activities. This is for NGOs and private practitioners. This is for district hospitals in government sector. And we also give non-recurring grant, and this is the amount that we keep on giving for various district, sub-district hospitals. IoT, we can see the amount which is significant, mobile ophthalmic unit and others. So till now I have talked till district level, but we have got tertiary eye care component as well. So we strengthen the eye departments of identified government medical colleges to be centers of excellence and RIOs. The amount is this. We support the strengthening of eye departments of government medical colleges for procurement of eye equipment, and the amount is this. So we keep on giving them the financial support at all levels. So regional institutes identified, this is a list of 20 institutes, we may increase or decrease this as per the requirements. Major IEC activities that we observe are World Glaucoma Week, this is the date, Eye Donation Fortnight, which would be coming in near future in a month or so, World Sight Day on the second Thursday of the October. All the data generated is compiled and plotted properly. So this is the cataract surgery performed from 2014 to 2021. We can see the dip at 2021 secondary to the corona pandemic. So these are all the figures which are compiled for cataract surgery, for school eye screening, for corneal transplantation and other eye diseases. We also train the eye surgeons of various states. So this is the figure for 2021, 50 surgeons we have already trained this year. So I think this won't interest you much. This is just the budgetary allocation of NHM as well as tertiary component. Once more, this I have already stated. So important thing is here, the portal, National Program for Control of Blindness and Visual Impairment portal. It has got the fed-in data from all the states, and in the real time we can see all the improvements or deteriorations out here. Major issues and hurdles. Whenever you work, there would be issues and hurdles. So low utilization of allotted funds by most of the states, low physical performance by all state UTs because of COVID-19, delay in NGO payment. This is very, very important and discouraging factor, but it is still there and it is part of life. Quality issues, sporadic reports of episodes of cluster endophthalmitis and blindness up to 7.2% because of that. So not only the states, the tertiary level shortcomings. Utilization certificates for grant are not given by RIOs. Physical progress report is not given by RIOs. They don't have modular IOTs, but they talk a lot. And they are not conducting training of eye surgeons in super specialty. I don't want to name the RIOs. Most of the RIOs don't have eye bank and trained corneal surgeons. Even the HMIS development and troubleshooting is not there. And the thing which worries me as a surgeon and now as ministry person is usage of off-label consumables throughout the country during our surgeries. Newer ideas, teleophthalmology has been mentioned by many speakers. We have got mobile units. We have got rotatory postings of eye surgeons of central and state cadre. And we want to start national uveitis survey because it involves the earning age group population. We want to implement the implantation of xenografts, artificial corneas, artificial bionic eyes as per recommendations of high-level scientific committee and NOTO through NPCBVI by 2047. So in a nutshell, what are the strategies that we follow? They are financial assistance, as I stated, HR support, monitoring of activities, and IEC activities. So these are the various important things that we follow. And finally, I thank you all for giving me a patient listening. Thank you very much.
Just like to make a statement, Dr. Hunt. Since you are now the technical control of the National Program for Control of Blindness, and you are saying that by 2047, you have now set a goal of 100% reduction in blindness. So for this planning and strategy formulation or of how you will go about it, because as you said, there are a lot of issues. And of course, including the HR management also, because many of the posts also are lying vacant in the states, PMOAs and other things. So there used to be an advisory committee who used to meet at least once in 6 months. Because of COVID, for last 2 years, no such meetings took place. So are you thinking of starting these advisory committee meetings? Because these advisory committee members do include lot of eminent ophthalmologists, apex RP centers chief, and of course the joint secretary and ADG and DDG from the ministry, and many NGO representatives who are doing a lot of work in the eye care field. So when are you thinking about restarting these advisory committee meetings? Because you'll get a lot of inputs for your planning and strategy.
Ma'am, that's a very good question, but I think Dr. Indu would agree with me that we have already moved files regarding the newer advisory committee, and
no, that is okay. You may form a new advisory committee. That is your prerogative.
Yeah. So we have already taken the steps, and the thing is under works.
Okay.
The moment the advisory committee is approved, we'll start the meetings.
That's fine. Thank you. Thank you.
Thank you very much.
Thank you, Dr. Rajesh. In fact, I'm really happy. In fact, what we were thinking that after 2020, there is no progress, there is no like target setting in the program. But it is nice to see that there are plans for 2027, 2032, and up to 47 for next 25-year planning is going on ministry at this stage. In fact, Dr. Rajesh has mentioned that two divisions. One is the technical head, another is the administrative head ministry. So Dr. Rajesh represents from the technical head. And from the administrative head, we have Dr. Indu Grewal with us. And in fact, she is now leading in a program which is related to elimination of cataract blindness backlog. I request Dr. Indu to speak about this initiative of cataract backlog blindness elimination program. Dr. Indu. This cataract blindness backlog.
Yes. Thank you very much. Respected Dr. Tityal, the Senior Faculty of RP Center AIMS, and Dr. Praveen Vashisht, thank you for inviting me here. And my mentor, Dr. Pramila Gupta, my colleague from Ministry, Dr. Hans. So my job is quite easy now because the stage has already been set by Dr. Vashisht about this showing of the data and what is the overall structure and the objectives of the program by the Dr. Hans. Now, I will be talking very specifically about the cataract blindness backlog free initiative. That what is this initiative and how we thought that it is doable and how we are going to take it forward, and in between how we are, because of COVID, it has made a specific dent in the program. There had been a number of surgeries at a tune of 65 lakhs, 66 lakhs every year. So suddenly we had a dent in that performance, and around 35 lakh surgeries could be performed, and there is a further increase in the backlog. So as you all have seen from the earlier presentations, there is a repetition, but repetition is always good because it does more and more advocacy, because you learn and you speak more of those things again and again, then definitely it calls for action. So we are able to reduce the prevalence of blindness from 1.1% to 0.36, as it has been clearly demonstrated in the National Blindness and Visual Impairment Survey. Just a second. Yes. That this graph you have already seen, that how the program has performed, and we have reached to 0.36%. And in the survey 2001 as well as in 2015-19, the cataract remains the predominant cause of avoidable blindness. It was 66.2%. So the cataract is the leading cause of blindness. Our policy, health policy 2017, the targets are to reduce the prevalence of blindness to 0.25% by 2025 and burden by 1/3 from the current levels. So based on these findings and our targets which are already set in our national health policy, so we have planned to work in a mission mode for 5 years, in which emphasis on cataract surgeries will be given where the visual acuity is less than or is equal to 6/18. This will be focusing on the bilateral blind, severe visual impairment, moderate vision impairment. So all these 3 categories will be more focused. In this, a DO letter has already been sent on 25th May 2021 that states have to make their action plans, and in their action plans they have to find out the gaps in terms of their infrastructure, what all equipments and their human resource. Based on this, they have to address these gaps, and the cataract surgical services needs to be improved so that we are able to generate a demand in the community. For that, we need to have a very good IEC, information, education and communication, so that there is an increased demand. We are ready for the provision of surgical facilities. So these all are there in this letter, and a document was also shared that how do they have to prepare themselves. To motivate them further, there is an award scheme. This award scheme is for the districts as well as the states, because a state cannot immediately apply for an award. So we will go from districts. For districts, the awards is gold medal, silver medal and bronze medal. Gold medal is 5 lakhs, 3 lakhs is silver medal and 2 lakhs is bronze medal. This function will be done at the state level. They will be felicitated, and in addition to this monetary award, and there is a medal also. So these are 2 types of award, the monetary as well as the non-monetary award. Likewise, it is there for the states also. So once they get these awards, then there is another award, that is a cataract backlog free district, for which we have a criteria. So that districts will be certified and a felicitation will be done, and then award amount is 10 lakhs per district. So on the similar lines, we have an award for the states. The state which is deserving the gold medal is 25 lakhs. For silver medal it is 15 lakhs, and for bronze medal it is 10 lakhs. And when the state is been certified as a cataract backlog free, then the award is 50 lakhs. So this is a good motivator, and once some of the districts are able to get the award, or some of the states, so it further motivates other states and districts. So what would be the procedure? We have advised to conduct a community level screening by Asha. She will be measuring the visual acuity, all those who have vision less than or equal to 6/18. So this record will be available.
So once these are recorded, the ASHA will be referring them to the health and wellness centers for cataract screening. They are the ophthalmic assistants or maybe the trained medical officers. They will be there who will be further screening these people who are listed by the ASHA. So next step is screening by ophthalmic assistant. Then there will be line listing of all these cataract cases, and then they will be referred to the nearest surgical facility based on the choice of the patient, that they wants to go for an NGO, they wants to go for a district hospital, or they want to go for a private hospital. The choice of the patient will be also one of the criteria for referring. It is not that these are the places only there you go and get the treatment. No, the patient's preference is also one of the criteria. So once we have the list and who all are referred there, that list will be given to ASHA. ASHA is a mobilizer in the field. So she will be ensuring that on the date of surgery, when they have planned, they are given the date, so she ensures that they go to the hospital and get them treated. They get the surgery done, and same way she will be ensuring the follow-up also. So now next step is once the surgeries are being undertaken in the hospital, so these surgeries will be done in a mission mode, and all these records at all levels are mandatory to be maintained. So we do not have so many government facilities, and since the program is there from 1976, we have lot many NGOs who are involved, who are performing surgeries, who are conducting screening camps. At present, we have 1,509 NGOs which are registered with us and who are working in different districts across the country. So the involvement of government, NGOs, private sector surgical facilities, everything is to be inclusive in this. And there is a specific allocations. We are including these many aims and RIOs also in this program. We are thinking on the lines to allocate them the areas. Then that we have some aspirational districts, and aspirational districts are one which one of the senior officer in the ministry has been the nodal in charge. So they will be the people who will be further boosting this, so that these aspirational districts, tribal areas and underserved areas all not left. So that the services are, the equity of services is there. All areas have the momentum of this backlog-free initiative. Then we need to have the strengthening of referral services for the management of sight-threatening complications. You know that every surgery have a risk. It might land up into a complication. So we need to have the right referral linkages and identified well in advance, so that if there is a need, they can be immediately referred to these tertiary institutes, eye care units like RIO, medical colleges, NGO hospitals, AIMS, all these places. So we need to have an advanced identification and development of linkages. So this is already there in our plan. Then finally, achieving a cataract blindness backlog-free status, then the Government of India would recognize by monetary and non-monetary award to the district or state for achieving cataract blindness backlog-free status. So this was about the steps, what are being followed. Then what additional things which are done. One is all these surgical service providers, all these hospitals, eye care hospitals needs to maintain the digital cataract surgical record. This is one. This should include the pre-operative and post-operative visual acuity, which is a must. Then uploading them on the NPCB-VI website. Dr. Hans has also talked about that website. Record should be available for scrutiny of the inspection and evaluation team, because when districts are applying for the award scheme, then there has to be some evaluation. So there will be a random check of those records. Based on that, they will be certified that they are now actually deserving it. Then the quality of cataract surgery is to be maintained. Pre-op and post-op vision is also one of the criteria, and all the records, because you have seen in the survey findings that we have these post-operative surgical complications have increased from as compared to the last survey. Now they are 7.2%. So we need to have a more focus on the quality of cataract surgeries. Then there are minimum benchmark standards which are qualitative as well as quantitative. This is cataract surgical coverage. This is a quantitative criteria. It should be above 98%. Then the post-operative complications should be less than 2%, and visual outcomes as per WHO criteria should not be less than, the vision should not be less than 6/16 in more than 5% of the operated cases. So these are the main three criteria. All those districts fulfilling these above criteria, they can propose for the award scheme. So who all will be doing this evaluation, assessment of that they actually have attained this status? So inspection of the relevant records, as I have been saying, at the surgical facility, at the health and wellness centers. Health and wellness centers are nothing but these are the under Ayushman Bharat. These are the sub-centers and primary health centers which are given a new name, health and wellness centers. And there is, earlier we used to have more focus on the maternal and child health services and family planning services at PHCs and sub-centers. They remain the more focus areas. But under this Ayushman Bharat scheme, Ayushman Bharat Health and Wellness Centers, there are addition of 12 packages of services in which eye is inclusive. Yes, okay ma'am. So the team which will be doing the evaluation, the ophthalmologist, state program officer and the senior officers from the regional director office, because this regional director office is representing the Ministry of Health and Family Welfare. Based on these recommendations, the districts will be awarded. So this is the score. I am just skipping. Then how the prize money and the certifications, I am just skipping. Now I am coming that what is the further development in intensification of the scheme. We have a brand new scheme, Rashtriya Netra Jyoti Abhiyan, which is going to be implemented in the next 3 years, starting from the current year, 2022, 23, 22, 24, 25. And for this, we are going to go for an announcement also at a higher level. The announcement dates are not been finalized, but whatever preparations are being done, I am just touching only those parts. So a DO letter has already been sent to the states by the Honorable Secretary, Union Secretary, Health and Family Welfare, that we are going to launch this scheme. States have to start preparations. District still remains the planning unit as it was there in our existing scheme. So what are the salient points in this DO letter? I will just highlight. The letter says that since because of COVID, there had been less number of surgeries. So now we want to further intensify our activities. So this blindness and severe visual impairment will be our primary focus area. That means this 3.95% prevalence we will be addressing more under this Rashtriya Netra Jyoti Abhiyan. So this, and there will be focus on these other categories also, but we would like to achieve this 100%. So this is the aim of this scheme. So under this, the estimates are being done. Dr. Vashisht has also shown those slides that how the calculations are being done. So that 50-year population, which comes out to be 21 crore, And if we see the blind, people will be around 28 lakhs. And bilateral eyes, if we consider, that comes out to be 49 lakhs. Similarly, for severe visual impairment, 53.6 lakhs are been the calculation. So if we add all this, we arrive to a number of 102 lakhs. Plus we are adding the incidence also. Because every year we are going to have new cases. For 3 years, we have added the incidence 60 lakhs. So 164 lakh surgeries, if we'll do in these 3 years, we will be able to remove the backlog of blindness as well as SVI cases, severe visual impairment cases. So, so our plan is, and in addition this, other cases, we are not saying that we will not perform other surgeries. So at a tune of around 105 to 106 lakhs, the other surgeries of other categories will also be performed. So total 270 lakh surgeries, cataract surgeries will be done in these 3 years, and these 75 lakhs in the first year, 90 lakhs in the second year, and 105 lakhs how we are going to increase every year, because as of now our capacity is 66 lakhs. From 66 lakhs we will be performing 75 lakhs, 75 to then 90 lakhs, and then 105 lakhs. So we have a portal. Yes, Rashtriya Netra Jyoti Abhiyan, the portal has been specifically designed for it, which will be capturing all these 270 lakh surgeries. Everyone, including the government facilities, tertiary level, whatever level, they have to enter all these entries so that we can count each 270 lakh surgeries. So that provisions are already been made. And there is a interview by the Honorable Health Secretary on that was on All India Radio. So with this message,
करा सकते हैं, उनके नाम और पते ये हैं, और अगर आप चाहें तो यहीं जहां आप आए हैं जिला अस्पताल में, यहां भी करा सकते हैं. तो ये तीनों विकल्प बेनिफिशियरी के पास है. जब वो विकल्प में से किसी एक का चयन कर लेते हैं, तब उनको तिथि की सूचना कर दी जाएगी, और वो उस तिथि को, नियत तिथि को, ऑन द डेजिग्नेटेड डेट वो ऑपरेशन होगा, और अगले दिन हम उनको दवा के साथ और गाइडेंस नोट एक देते हैं कि आपको क्या करना है, क्या नहीं करना है, उसके साथ, और काले चश्मे जो उनको लगा के रखने हैं उसके साथ वहाँ से विदा करेंगे. और जो हमारी आशा बहनें हैं और ऑक्सिलरी नर्स मिडवाइफ्स हैं, वो उनकी मॉनिटरिंग करेंगे. माध्यम से करा सकते हैं, उनके नाम और पते ये हैं. और
so with this I thank you everyone and I end my talk.
Thank you. Thank you, Dr. Indu. I believe it's a big challenge for our country. Currently, we are performing nearly 65 lakh surgeries per year, and targeting 70 and then 90 and then 110 lakh surgeries. Probably, a lot of initiative are needed for that. Thank you very much. In fact, we are short of time, but I request Dr. Fenendra to speak about, sir, around 5 to 7 minutes, possible. Vision 2020 Right to Sight initiative in India, sir. Thank you.
Thank you. So my due respects to Professor Titya, Madam Professor Radhika, and our advisor Dr. Pardila ma'am, and NPCB official Dr. Rajesh Hams and Dr. Hindu, and special thanks to Dr. Praveen for this opportunity. Very quickly, because I just have only 7 minutes time. This is just a kind of vision and mission statements. I'm not actually taking you through this. Just have a very quick look at it. So just be 5 seconds on the screen for you. Out of 7 minutes, you can take 7 seconds. Okay, 7 seconds are over. Thank you. This is actually very, I think these are very important initiatives that Vision 2020 have taken up. So one of them is jointly with RP Center way back in 2017. RP Center and Vision 2020 spoke to NPCB for the change of definition. This is what morning Dr. Praveen has presented, and also Dr. Rajesh and some other have presented. So definition has got changed from less than 6 by 60 to less than 3 by 60. in 2017. This was actually as a result of joint initiative by RP Center and Vision 2020. So there were actually a kind of the NPCB officials were invited to the board of Vision 2020. There was a discussion, then NPCB we submitted a representation. It was actually NPCB set up a team, a technical team. That's how the technical team had reviewed it and then provided comments. Finally, after 6 months' time, very swift action was taken by NPCB of changing the definition from the earlier 6/60 to now 3/60, because of which now we are able to compare our blindness prevalence surveys, prevalence of India across with other neighboring countries. So figures and the prevalence rates are now comparable with other neighboring countries. Otherwise, like, earlier we used to have a problem. So the other one is the cataract grant in aid in cataract reimbursement from 1,000 rupees 2012 to 2,000 rupees 2018. Again, the Vision 2020, the joint secretaries of NPCB earlier, Sri Love Agrawalji, and earlier Madam Daritri Panda, and also earlier Sri Karnacobar Pandaji, I remember, that was speaking to them. So they were actually advisors to Vision 2020. So these kind of issues we discussed in the board meeting with the joint secretaries earlier. And so we made a representation to consider increase the grant in aid from 1,000 rupees to 2,000 rupees for cataract, and also for other eye care conditions like keratoplasty or the spectacle distribution from 250 to 375 rupees like that. So there was again after 9 months of necessary follow-up, the NPCB has taken a very swift action again. So you could see the kind of increase from 1,000 rupees to 2,000 rupees for cataract in 2018. So this is actually kind of initiated by Vision 2020 in 2017, and then it resulted in 2018. Few other aspects are very important. Cataract was actually to be removed from the Ayushman scheme in 2019 September. So we had discussion with NPCB. We wrote to kind of a representation to Niti Aayog, and so this tripartite kind of information we ensured. Finally, very quickly, just to inform you that cataract is now retained in Ayushman Bharat as a result of a very collaborative approach led by Vision 2020, and also in partnership with NPCB for this. NPCB, we are really thankful for supporting Vision 2020 stand on this, and so therefore now we could see cataract is retained in the Ayushman scheme since 2019, and I hope it will retain for some more time at least. And second one is about the reimbursement to NGOs, which Dr. Rajesh has actually very briefly mentioned, but delays in NGOs payment, we just actually mentioned a few minutes back. So, which is true, currently there are issues about the reimbursements, particularly in states like Uttar Pradesh, Bihar, and Rajasthan, and many other states as well. But sometime ago in 2016 and 2020, again with the support of NPCB, led by Vision 2020, the NGOs got the reimbursement to a greater extent, but still this issue remains. I think one has to really look into this issue on a more permanent basis. The ministry actually had thought of closing down the diploma courses in allied ophthalmic personnel beyond year 2020. Sometime back there was a notification that beyond year 2020 there won't be any diploma courses for ophthalmic personnel in the country. But I think that's it's not a good idea. We felt that we actually had a discussion with Joint Secretary Human Resources and other ministry officials, informing about the need of having this cadre, particularly when we're talking about primary care. Morning, Dr. Pallavi and others spoke at the end about primary care. So if you actually need to talk about primary care, this is the kind of the human resource cadre that is very much inevitable to ensure the eye care. So we had a representation discussion, and then as a result of it, now diploma courses will continue in India as long as they are needed in the country. The other one very important aspect of the Drug Control Authority was considering keeping the spectacles in the medical devices category. As per WHO, only assistive devices for ophthalmic cadre were considered in the medical devices category, but not the spectacles. So again, we spoke and met and made a representation to the Drug Control Authority to declassify the spectacles for the medical devices, which is actually accepted in August 2021. So this provides a hassle-free business environment for the optical industry, and also for people to have easy access to spectacles. The very important aspect of the guidelines, the Vision 2020 had set up a technical team, and this is the kind of guidelines was technically reviewed by NPCB, AIOS, and ISM SICS, which is the International Society for Manual SICS. This is the kind of manual we had redesigned and reworked on it in year 2020. we have taken committee, including faculty from RP Center for this. We have an upcoming conference, Leave No One Behind, on 3rd and 4th of September 2022. This upcoming in Siliguri, West Bengal. This conference focuses on exclusion community ophthalmology. So I think this is a very good platform to let you know that we are actually organizing this conference with the Lions Club initiative in Siliguri. Kindly save the date and please do participate in this. Very important, the way forward for strategy, we are guided by our own strategic plan for next 5 years from 21 to 26. With these 5 objectives, universalize, consolidate, systematize, coordinate and advocate. Universalize essentially demonstrating the possibility of achieving universal eye health. With a more of denominator-based approach, because right now we all maintain the number of cataract surgeries done, number of people provided spectacles, etc., and output-based indicators. But I think we need to really think about changing in our indicator forms also, keeping the denominators. Like now we need to see what, just we had presentations from Dr. Hindu where she talked about the percentages also, like the cataract bacular-free initiatives. The cataract surgical coverage, etc., where we actually get into percentages. So at any point of time, you will know what is the need of the cataract burden, out of which what is the kind of cataract the coverage. Therefore, that's kind of universalization we are talking about with the denominator-based approach. The consolidate one, second one important, is consolidation of the resources. So under which we are talking about primarily the district level models. That means the under the public-private partnerships, ensuring the primary eye care services at the district healthcare facilities through integrated approach. Again, we had briefly had talk from Dr. Pallavi in the morning. So that's kind of a consolidation of resources we are talking about to ensure the primary eye care services at the district level. Third one, systematize. Again, HMIs, again spoke by Dr. Rajesh Hans very well. And the IEC again spoke by Dr. Hindu, which is IEC material we have, but I think we also need BCC material in eye care. We have IC material very well by RP Center and by NPCB, but essentially they spoke about the symptoms of which when you have red eye, you kind of think if you have broad vision, maybe it could be cataract, something like this. But I think, what happened? I can't see my screen. It is here, but I can't see my screen. Okay, great. That Praveen just give me only one. I think I still have 50 maybe seconds also, so I quickly take you through this. So the systematized, we have BCC I'm talking about. BCC essentially something I think we have very good material in the HIV prevention programs for the behavioral change of the community, and also in the family planning programs. Very extensive and very useful material of BCC. I think such kind of material what we require for eye care also, that could be used during interpersonal communication by ASHA workers or any other community-based volunteers at the ground level. That's what actually we are talking about the HMIs and HMIs, BCC material kind of the technological support. And the systematized, coordinate, as you know very well, this is a cross-cutting theme, objective of achieving the eye health across the country, whether it's across the sectors or departments or ministries. Coordination is the key for all of us, whether it's the Minister of Education, Minister of Socialist Empowerment, Minister of Health, Minister of Labor, or any other ministry. I think coordination is required. Advocate is a prime objective of Vision 2020, where actually we bring in issues to the notice of NPCB. We speak to them and bring some kind of policy improvements, as you just a few of them right now. So I think so that's all I have. Thank you so much. I hope I'm within 7 minutes.
Thank you, Mr. Fenendra, for keeping to time limits. In fact, we feel happy that RP Center was part of this developing this strategic plan for Vision 2020, right to sight, and we are also now planning to part of the implementation process also. Thank you very much, Fenendra. In fact, before we conclude this session, I request Professor Tityal sir, Radhika madam to give mementos to the guest actually. Meera, Dr. Pramila Gupta, I think you are the guest, ma'am. Chief guest. those low vision program speakers to come here for a group photograph. Next two sessions. And also the organizing team members, they can also join. Thank you. I'll request all to break for a cup of tea, and we can start the next session after 10 minutes. 11:50 exit. Thank you so much.
आई के साथ रखना है तो सर में वो डिस्टेंस बिटवीन ऑब्जेक्टिव लेंस हम ऐसे यूज करके देखो
Check.
the screen is over also. So, good afternoon, respected faculty members and the delegates. So, as we are heading towards the our third session, which will be on the low vision clinical services, I would like to invite Professor Radhika Tandon ma'am and Professor Vanathi ma'am to chair the session, and also Professor Pradeep Venkatesh sir and Professor Bhavna Chawla ma'am to join online.
Thank you so much, Amit. So, welcome back to the next segment of this workshop. We're going to cover the session on clinical services related to low vision. And the first speaker is our senior resident, Dr. Amit Das, a very young and budding and very promising ophthalmologist, excellent surgeon. He's going to cover current concepts in definition, evaluation, and intervention. This is extremely important that everybody is clear and thorough about this concept, because often people make errors in certification and also in guiding people for certification. Over to you, Amit.
Thank you so much, ma'am. So I am starting my presentation. So I'll be discussing about the definition, evaluation, intervention, and followed by Dr. Tanveer will be discussing about the global burden, and after that Ms. Sneha will be discussing about the new perspective in management, and after that Professor Radhika ma'am on operation research. So as per the current notification given by the WHO, the globally at least 2.2 billion people have vision impairment. In almost half, that is 1 billion of these cases, vision impairment could have been prevented or has yet to be addressed. So the leading cause of vision impairment of the blindness are uncorrected refractive error and the cataracts. So coming to the definition, so the ICD 11 in 2018 revision has defined the classification, defined the vision impairment into two groups, that is a distance and near presenting visual impairment, which says that if the distance vision, visual acuity, if it is worse than 612 to 618, it will be mild. If it is 618 to 660, it will be moderate. If it is 660 to 3 by 60, it will be severe. And if it is less than 3 by 60, then it will be called as a blindness. While the upper third will be called as impairment, and the last one will be called as a blindness. The near vision has also been included in this classification, which says that the near vision acuity, if it is worse than N6, then it will be called as a vision impairment. So this is this chart has been taken from the WHO website, which says, as I have discussed in the previous slide. So there's it has been categorized also in as a 0, 1, 2, 3, and 4, while the 0 and 1 will the mild and moderate visual impairment, 2 being the severe, and 3 and 4 being the blindness. So now coming to the functional low vision definition, which is defined as a visual acuity less than 6 by 18 up to the perception of light, with treatment and best possible refractive correction, or the visual field less than 10 degrees from the point of fixation. This is an important definition for the sake of the evaluation, and because a person with this vision may benefit from low vision devices and the services. So coming to the low vision evaluation or assessment. So what are the common causes of low vision? These are the glaucoma, diabetic retinopathy, optic atrophy, retinitis pigmentosa, ROP, retinal degeneration, and the corneal ectasia. So these are the tools of assessment for the low vision assessment for the low vision. So what are the goals of the assessing low vision? So to address the visual demands of the patient, identify and evaluate the cause of low vision, assess the ocular health, emphasize the need of the patient and beneficiary, clinical assessment, maintain and improve the visual function, optometric rehabilitation and intervention, improve the functional, improve the performance using low vision aids and rehabilitative strategies, and counseling and educating the families, teachers, and others. So the complete low vision assessment involves history taking, visual acuity, refraction, contrast sensitivity, color vision, glare sensitivity, and visual fields. So coming to the first, there's ocular history. So we need to find out the cause of the low vision, the onset of the vision loss, which is gradual or sudden. We need to see the status, whether it is a progressive or stable, whether any medical, surgical, laser treatment has been done or not, if there is any family history or consanguinity, retinitis pigmentosa or myopia is there or not. So questions regarding the low vision health requirements should be asked in detail, like reading and near vision. Does the patient need to wish their reading specific materials, newspapers or not? Whether he can do the intermediate activities to writing, sewing, cooking or not. Activities of daily living, we have to also see, like the patient can do his or her daily routine work, like cleaning and washing or not. Educational activities, are they doing good or not? History of using the low vision devices is there or not? And there is a vocational history has to also be taken, like the patient is the patient is employed or not, what type of work he was doing in the past, and whether the patient wants for the is now seeking for the employment or not. So the distance acuity we need to measure because it gives a baseline to monitor pathology, but it also helps to predict the magnification level of the optical devices. So performed at a distance of 3 meters, and most commonly used charts are Bailey-Lovie logmar chart and ETDRS charts. So characteristics of these charts are these are the 5-letter row, and each row has letter of the equal difficulty to read. Consistency in spacing between the letters and line. Size progression of letters is logarithmic. These are more reliable. So this is the Bailey-Lovie logmar chart. So this chart has come as a 2 set of panels. There are 14 rows with a range of sizes from 38 to 1.9 in M units. Sizes are also given in the Snell's units for a 6-meter viewing distance. And ETDRS charts also we use. It has a specific design criteria to be more accurate. The same number, it has the same number plate as same number of letters in row, equal spacing and rows and letters on a log scale also there. Now come to optokinetic drum test. So it is used to predict the presence of functional acuity. A brisk response from a 1 to 3 feet can be interpreted as a potential for some functional vision, and response from 5 feet is an excellent prognosis for the functional visual function. So specific activities customized as per the need for the profession of the patient to be checked: blackboard or TV for the school going children, and recognizing faces and reading the bus numbers and the metro stations for adults. So coming to the near acuity. So near acuity, it is usually tested with a lighthouse near acuity charts. It provides a starting point for near point magnification. Initially, to start with this chart, and it is rated at 40 centimeter distance. It is usually, there are 2 types of notations, M and N. So M notation is a method of choice. It's a metric notation, represents the distance in meters at which the target subtends an angle of 5 degrees of arc. And next is the N notation, which is a point size of a lowercase in a Times Roman print, which is valid, and also if the size is size of the N notation is divided by 8, then it gives the M unit. So this is the typoscope. This is it's a kind of reading slate which should also be demonstrated when measuring the near acuities. If a typoscope improves the patient's acuity, the patient may have a eccentric viewing problem, or the patient might require high contrast. Now coming to the refraction and retinoscopy. So all visually impaired patients should go for refraction to ensure optimal correction for achieving best corrected visual acuity. So most low vision devices are used in conjunction of refractive correction, and presence of uncorrected presbyopia and significant uncorrected refractive error could affect the success of the low vision devices. So Coming to the objective refraction. So autorefractometers have a limited use due to problems in the media and because of the eccentric weaving. So if the patient has previous glasses, that can be a good point of starting the refraction. Just to make sure that the patient is wearing his or her own glasses. Keratometry is useful for a patient with a high amount of astigmatism to know the cylinder, and the patient patient may have difficulty to fixation. This can be helpful in detecting irregular corneal surfaces and irregular astigmatism. Retinoscopy are useful, especially in patient with poor responder. It may be necessary to use a radical retinoscopy. What is radical retinoscopy? That means the working distance is drastically reduced. That is as close as 10 centimeter. So it also gives deliberate off-axis scoping to use the visible reflex, but it also induces unwanted cylinder, but the results can be appreciable. Coming to the subjective refraction, so it can be done under these headings, like a general condition, the trial frame, just noticeable difference, spherical and cylindrical refraction, and the stenopic slit and multiple pinhole lenses. So coming to the first point is that it should be used at a 10 feet or lesser working distance. We should use a full illumination unless otherwise it is indicated, and use a low vision chart in subjective refraction. Always do a trial frame refraction. That has to be done. Next is just JND, that is just noticeable difference. It means that the smallest dioptric step that a patient is able to discriminate. Usually 0.25 diopter steps are avoided because of the vision impairment, the patient can only notice the one diopter change only. So we use the 10 feet equivalent distance as a rough starting point for the JND. Coming to the spherical refraction, so the tentative result from the objective refraction is used as a starting point. It determines the JND lens. First determine the JND lens and check the sphere value with that. So we have to ask the patient better with the lens or without it, not one or two, because the patient might get confused with that. So patient may have a poor slow valuable response, but maybe due to the because of the pathology. Now the cylinder refraction that can be done with the Jackson's handheld Jackson's cross cylinder of 0.5 or 1 diopter. Cylinder power is checked in a normal way. Yes. So coming to the contrast sensitivity, so this can be checked by the Pelly-Robson contrast sensitivity chart. So these are the letters of the same size with the reducing contrast. So it is read at 1 meter distance. And another chart is a FACT chart, that is a functional acuity contrast test, which also comprises with a sign grating varying from the varying frequencies and which increases from top to bottom and varying contrast from left to right. Other methods are Bailey-Lovie chart, VCTS system, Arden plates. So there are other methods of the contrast sensitivity testing. Coming to the color vision, it is usually tested with the Ishihara chart, but for the low vision, for the patient with low vision, so Farnsworth Munsell D15 is a good choice because it is relatively quick and is more informative, and it is easily to administer. Coming to the glare sensitivity, so it is usually tested. What are the causes of the glare sensitivity? So rod monochromatism, the PCO, corneal opacities, glaucoma, congenital cataract, and lasered PDR, albinism, and iridia. So it is usually tested with the glare acuity tester available in the market. Now coming to the visual field. Visual field is also necessary to determine and to certify the low vision and the blindness. So for that, we usually do confrontation test But for the low vision patient, we need to have a central and the peripheral visual field has to be tested. So for the central, the Amsler grid test has to be used, which actually which tests the central 20-degree of the visual fields, and the patient notices any kind of distortion around the center of the visual field. So it is usually undertaken as 1/3 meter with the opposite eye closed. So coming to the GVF, there's Goldman Visual Field Test. So it's a manual perimeter. And lastly, coming to the electrophysiological test, which are the ERG, electroretinogram, electrooculogram, EOG, visual evoke potentials, VEP. So these are potentially helpful for the cortical blindness and mentally retarded infants, in whom the visual acuity testing is difficult and with a poor prognosis. And lastly, the ocular health assessment is also necessary. We need to see the adnexa, lids, conjunctiva, cornea, iris. The biomicroscopic examination has to be done. The tonometry, the IOP measurement has to be done. And the central and the peripheral fundus examination with the dilated pupil has to be done. I sincerely acknowledge Dr. Radhika Tandon ma'am, Dr. Sumit Grover, Dr. Sovik Manna, Dr. Ms. Sneha Agarwal for this presentation. Thank you so much.
Thank you very much, Amit. I had requested him to be a little brief because we had overstepped the time in the previous session, and he nicely covered the topic. 2-3 important things to take from Amit's lecture is, one is that, when you're defining, you have to understand the purpose for which the patient has come to you. The patient may simply have come to get improvement in vision. Plus, when you're talking about certification, certain things need to be kept in mind. When you're actually certifying a person with a disability certificate nowadays, it has to be considered as a permanent disability. Okay, that's important. The only exception is temporary certification for children if they require it, or young students if they require it for purpose of appearing in exams. So this is the modification of the Person with Disabilities Act which has come in. So when certifying, it has to be a permanent disability, with the exception of if students are coming specifically for help with a writer during an exam or something like that. The other thing Amit said nicely is of course, what he's covered is the routine workup of the patient, but certain nuances are to be taken into account when you are looking at a patient from a low vision perspective. So from that point of view, he has covered that there are certain modifications that you may have to do in the assessment. Thanks a lot, Amit.
Thank
and
you,
then we can go ahead with the next talk, which is by Dr. Tanveer on global burden and factors responsible. Dr. Tanveer is also senior resident and also a very good surgeon and very good at his work.
Good afternoon, one and all. So in a previous presentation of today's workshop, we have mainly focused on the status of blindness and visual impairment in our country. Now I'll be talking about the global burden of low vision and the factors responsible. So blindness and low vision affects millions of people worldwide, and a majority of these causes of vision loss are either preventable or curable. And as stated earlier also, the WHO definitions of blindness and low vision. Blindness is defined as presenting visual acuity less than 3/60 in the better eye, and moderate to severe vision impairment is less than 6/18, and mild vision impairment is less than 6/12 in the better eye. So these are the global burden of disease super regions. These regions are actually based on a regional classification system by WHO and International Agency for Prevention of Blindness. These super regions are created based on the epidemiological similarity, the similar factors, the prevalence of blindness, and the geographical closeness. So there is a region of Central Asia, Southeast Asia and Oceania, South Asia, North Africa, Sub-Saharan Africa, high-income countries. So these regions have similar prevalence of diseases in them and have a geographical closeness also. Now coming to the global causes of blindness as in 2020 by WHO. So there are 43 million blind people all over the world, and out of them 17 million are cataracts, 16 million are other vision loss, 4 million are uncorrected refractive error, 2 million are macular degeneration, 1 million is diabetic retinopathy, and 4 million is glaucoma. And coming to the global causes of low vision in 2020 by WHO, there are 295 million people with moderate to severe visual impairment, and the maximum of them, 157 million, are of uncorrected refractive error. Then 83 million are cataracts, 40 million are other causes, and 6 million macular degeneration, 4 million glaucoma, and 3 million are diabetic retinopathy patients. These are the global figures of vision loss, both blindness and low vision. So cataract is the, so uncorrected refractive error is the leading here, 161.2 million, then cataract 100 million, then other causes 56 million, and followed by age-related macular degeneration, glaucoma, and diabetic retinopathy. So coming to the global burden of cataract, since cataract is the leading cause of blindness all over the world, and it is responsible for blindness in 17 million people and vision impairment in around 83.5 million people. This is for all ages. And if we see in 50 plus population, it is leading cause of blindness around 45% and second largest cause of vision impairment, around 38%. And then coming to the global burden of uncorrected refractive error. Uncorrected refractive error is the leading cause for vision impairment all around the world, and it is responsible for blindness in 3.7 million and vision impairment in 157 million. And if we see in 50 plus population, it is the leading cause of vision impairment, as I stated earlier, in 42% people. Now coming to the contribution of each cause of total burden of blindness in age 50 plus. So cataract is the leading cause with 45%, then our other causes 29%, followed by glaucoma 11%, then uncorrected refractive error, ARMD, and diabetic retinopathy. And if we see the contribution to the burden of low vision, then uncorrected refractive error is the leading cause worldwide, 42%, followed by cataract, 38%, then other causes, then ARMD, glaucoma, and diabetic retinopathy. So if we see the change in numbers affected by each cause of vision loss, we can find that from 1990 till 2020, the number of people affected by each cause, be it cataract, refractive error, or other causes, or glaucoma, they have increased in number. So all causes of vision loss in 50 plus population have increased in number since 1990, over the period of 30 years. But if we see the prevalence, age standardized prevalence of each cause of vision loss in the 50 plus population, we can see the percentage prevalence has actually decreased for each cause, cataract, refractive error, glaucoma, ARMD. So the prevalence of blindness has actually decreased since 1990. And if we see the relative contribution of each cause of vision loss by 10-year subgroups, we can see that in the initial ages, 50 to 60, refractive error are the major cause of vision loss, but as the age advances, cataract and ARMD and other causes take over, and refractive error decreases. And if we see the prevalence of vision, each cause of vision loss by gender, we can see that almost in each category, cataract, refractive error, glaucoma, in everything, female have more prevalence of blindness and vision impairment than males. So women and girls experience higher rates of blindness and vision impairment at every stage of their lives. And if we see global numbers and prevalence of each cause of vision loss, we can see regional disparities also. We can see the cataracts and diabetic retinopathy, these are more in the low developed countries. And if we see regional disparities for global numbers of vision loss, we can find that the low-income countries such as Sub-Saharan Africa, South Asia, Southeast Asia, North Africa, these have more number of people whose vision impairment is yet to be addressed. While in high-income countries, we see that the people with vision impairment have their problems already addressed. So the prevalence of vision impairment in low to middle income countries is actually 4 times higher than high income countries. And we can see regional disparities in the near vision impairment also. We can see that in high income countries, people have near vision impairment, presbyopia, but they have already been corrected. While on the other side of the graph, the Southeast Asian, Sub-Saharan countries, these people have presbyopia, but they have not yet been corrected. And the prevalence of near vision impairment is actually corresponding with life expectancy also. The countries which have longer life expectancy have more prevalence of near vision impairment. And these are global projections. So these are projected number of people estimated to have myopia and high myopia for each decade. So we can see that both the prevalence, both the number of people for myopia and high myopia are going to increase by 2030, and they can reach up to 3,000 million and 516 million respectively. And similarly, the projected numbers of people with glaucoma and ARMD are also going to increase by the year 2030, and they are going to be 243 million and 95 million respectively. Okay, now coming to the financial burden due to vision loss. Vision impairment poses an enormous global financial burden. For example, by an estimate of IAPB, the global cost of productivity loss due to uncorrected myopia and presbyopia are $244 billions and $25.4 billion. So that's a huge amount. Coming to the take-home messages, vision loss impacts people across their lives. However, the most reliable data on the causes of vision loss is only available for adults over 50 years. And second thing, the prevalence of blindness has decreased since 1990 for all causes except diabetic retinopathy, which has increased. So this is a reassuring change in the right direction. However, the number of adults with vision loss has increased, with increase in population actually, and significant inequalities also persist between the countries. So it indicates that these services are actually failing to meet the population demands in equitable manner. And finally, more comprehensive data is required to provide more accurate country level data and more data on vision loss in younger adults and children. Thank you.
Yeah. So thank you, Tanveer. So as Amit had also mentioned, that near vision is also included as impairment in near vision is also included in low vision impairment, and Tanveer has nicely consolidated the information from across the world. And basically it highlights that age is a very important factor. Dr. Tityal also said earlier that it increases life expectancy. So we have to start preparing for the future and to make sure that all these policy decisions are taken to account for all this extra work that is going to be required. Thank you so much, Tanveer. So we go ahead now with the next lecture, which is New Perspectives in Management. Lecture will be by Ms. Sneha Agarwal, who is posted with us in the Low Vision Services Clinic and has helped us in this journey in providing the services to the patients at RP Center.
Thank you, ma'am.
Sneha, just be a little brief because we've lost time. Yeah.
Thank you, ma'am. Good afternoon, everyone. So I'm going to talk about new perspectives in low vision management. So it has already been explained by Dr. Amit what are the goals for the comprehensive low vision care and management. And when we talk about visual impairment, it is not only the vision we're going to talk about it. What are the elements of the vision? Like there is a reduced contrast, visual field, photophobia, diplopia. So a lot of challenges are also coming along with the vision, reduced vision. And these are the elements of vision which going to set the stage for the development of low vision devices. So these are the kind of patients who require the tailored interventions from different disorders. So we can't aim the same same kind of device for the poor vision or for the contrast. So each type of challenge requires a specific type of device. And what are the common challenges faced? The patients who are having the central visual loss of central vision, loss of peripheral vision, and cloudy media, they all have different challenges, and decreased acuity leading to poor vision for distance, for near, inability to recognize distance objects, and more the central visual field loss causes a lot of scotoma in the central, where the location of scotoma is very important. It causes the generalized loss of visual field, and mobility and daily activities of living are restricted by all these things. So the whole concept is to make the object or the target bigger, bolder, and brighter. But when we aim, we are, inviting a lot of distortions or aberrations in the vision. So as we go bigger, there is a pincushion distortion by the optical devices, and the reading, there is a close reading distance, and there is a fixation requires. As we go bolder, the reading speed decreases, and brighter, because we don't know what kind of patient accept the yellow light or the white light. So there is why to prescribe the low vision devices. to reduce the time spent with disability and to make the person more independent. And in the long run, there has been change in the paradigm of low vision aids. So now there are software applications in the mobile laptops. Artificial intelligence plays a very important role. Magnifiers and telescopes, not only the optical. There was a time we used to talk about optical and non-optical aids, but now we talk a lot about this AI devices and softwares. There are the auditory substitutions like ORCAM and smart vision spectacles, which are the scanners and readers. There is visual video feed. There are a lot of devices which use the smart techniques and kind of augmented reality. So why assistive devices are optical devices? Improved lighting, better contrast, and there is a reduced glare. And the literature says too. And what is a good prognosis for success? The nature and extent of vision loss, we never target to make the patient 6/6 or N6. We have the specific goals for rehabilitation depending upon the patient needs, physical and mental abilities, and the attitude. And the number of frequency of follow-up visits, will depend upon the stability of eye condition, patient response, and specific visual devices. So there has been an evolution in low vision devices. We started with the telescopes, binocular telescopes and CTV glasses. I'm going to talk about it in very brief. These are the optical low vision devices, which are uniocular, handheld, spectacle mounted, and CTV spectacles, Ocutex. So you see, the devices which were handheld have become the worn, we can wear the glasses, and the devices look has also changed. So there has been an aesthetics and increase in the optical quality of the devices as well. So telescope has its own advantages and disadvantages. It reduces the field of vision. There is a ring scotoma. Hands are not free. Extra training is required, but still, it is the most economic and ergonomic devices in terms of distance vision devices. Now we have the CTV glasses, which are quite, taken up by the students, school-going children for watching television and school blackboard. But there is a conventional prescription which cannot be given. Ocutex side scope, in these glasses, the conventional prescription of glasses can be given, but it is available in low range of magnification and need to be incorporated on a specific frame, and it is not economical. Then VS sports biopic glasses, high level of magnification is possible in this, but and the image resolution clarity is very nice, but again, it is not economical. Learning curve is required, and there is a prescription of refractive error is a challenge. So rehabilitation of visually impaired, the artificial intelligence and the assistive technology, which is the new frontier, works on three, fundamentals. One is the image enhancement, visual field enhancement, and accessibility. New Eyes 2 and New Eyes Pro glasses, which we have in our center and low vision services lab, are the augmented reality based devices which help us in image enhancement, changing contrast. They have the scanner and reader, can read the text for the distance and near. Iris vision system, a very simple kind of a device with the very good clarity. E-sight glasses, where we can also track what the patient is seeing, and very helpful for the patient training. A-sight and E-sight, so these are kind of different models which have been brought up by different companies, but they are very costly, like not affordable by economical patient. Vuzix Blade smart glasses, there is a kind of holographic image which is created on the type of the glass, and they kind of the smart watches. So visual field is particularly important with respect to mobility and the legal driving standards. We used to give, there was a time we used to give the reverse telescopes, but now we have this oxide glasses for peripheral visual field enhancement, and the onyx glasses for the central visual field enhancement, but a lot of studies needs to be conducted on the feasibility of the device. ORCAM is a kind of a scanner and reader, the kind of a wearable device which helps in assistive technology, and the patient doesn't have to see. So it doesn't give a visual input to the patient, only the patient has to wear the glasses. And this device can read, uses the artificial intelligence technology, and can scan the whole target without just scanning it by once. Smart vision glasses, which have been recently launched in our center, are the Indian-made version, and they are available in 27 Indian regional languages. Incorporates the Braille Edge device and facilitates mobility. So optical and digital devices for near, these are the like spectacle magnifiers, dome handheld magnifiers, and we have also seen a great shift in terms of video magnifiers. So spectacle magnifiers have the conventional and the most acceptable modality, but comes with the disadvantage of fixed reading distance and fixed optical center. Writing is difficult, obstructs illumination. Handheld magnifiers, again, a very easy technique, even used by other professionals, but they have, again, their occupies both hands, patient can't write, if difficult to use with the tremor patient. Stand magnifiers use a predictable focus. Patient has to bend and see. It has a specific focus, so cannot be used in all kind of environment. Now we have the video magnifiers, which has great working distance, large visual field effects. The patient who have less than 5 degrees can also be used. They have a very good contrast. Even the mode can be changed, like black on white, white on black, blue on yellow. And now few of the devices are also available with the OCR, this thing, and they have different types, even the video magnifiers and desktop magnifiers. Non-optical devices, we do underestimate a lot of them, but life-changing for the patients by simply giving a good glare, a good lighting system, can doing a simple environmental modification can do a lot of wonders. And these are the kind of modifications we have given to a very high myopic patient who was around -26 and was having like 1/60 vision, but the patient parent were quite like they are making a lot of efforts and interested to go ahead with the normal education. So she is enrolled into the integrated education using the special techniques. So all these things have been modified for her. So illumination, this is now a big problem, how to focus light, which kind of light, and again there is a shadow image with that. Reading stands are a great tool, relative size devices where we can have the enlarged print, computer softwares like NVIDIA and Magic Screen softwares, JAWS, pinhole glasses for the corneal opacity patients, mobility assistive devices, field expanding devices, tips for low vision aids prescription, optimum print size, contrast needs to be maintained. We need to be very careful about the lighting and glare. Magnification needs to be appropriately realized. It is not important to particularly give a very high magnification, whatever the patient needs as per the profession and vocational activities. Viewing strategies, sometimes the patient field is very poor, so eccentric fixation helps a lot, contrast enhancement. So these are the few of the low vision apps. And what are the barriers? Basically, I would like to highlight this point. There's a clear ownership needs to be established, because none of the devices are being covered under any of the policies where the patients really can't afford, and they need to be integrated into primary eye care. And we need to increase the range of products for service provision. Moreover, Make in India plan as also brought up by our chief. And do we need, so I'm going to skip this, the retinal prosthesis and Argus. There are few implants, bionic eye, which have come into the studies, and the clinical trials are also going on, gene therapy and optogenetics. But I would like to emphasize the need for the early intervention is the best rehabilitation intervention. And thank you so much.
Thank you very much, Sneha. I think that is a comprehensive coverage, and one needs to know the variety and the ranges of low vision devices which are available, and they need to know for what type of disability which is the best device, and that's a huge learning, and I think she's thrown a lot of light from her experience in this aspect. We will now move on to Professor Radhika Tandon, and ma'am needs no introduction. Huge contributions in instilling and the running of the low vision services at our center. Over to you, ma'am, on operational research and modeling.
Thank you very much, Vanity. So as Sneha covered in her lecture, there is such a variety of options, and with each patient you have to customize it. So I'm just going to give you a little snapshot about what I mean by operational research and modeling through my talk. So first, to give a little bit about the impact and outcomes of clinical interventions in low vision services. Okay, the concept now is disability inclusive eye health. That concept means that you have to give eye health to everybody, even if you can't do anything specifically in terms of surgery to restore their vision. You have to make some effort to give them some kind of a help, and I will give you examples. So the idea is empowering people with disabilities. So they have to be given equal opportunities for all walks of life. Let us not neglect the importance of education, entertainment, mental well-being. So protection of rights and full participation in society. So the good to know list is, we've already covered with the help of Amit's talk, that what do we mean by disability, then what is the benchmark disability, that is 40%, right? Anybody below, so all the benefits which you are going to get for government jobs or any other aids or financial aids, etc., comes if you are worse than 40%. What are the types, what is rehabilitation, what is discrimination, what is the barrier, and so on. The definition of blindness and visual impairment is another thing which is important. And as Amit mentioned, I am again emphasizing near vision. So keep that in mind, that even the inability to read near, which is so common. Presbyopia, all of us have it as well. So technically we are visual impaired if we don't wear glasses. So this is important. And then remember that when you're talking about certification, it has to be permanent. So often people will come with a one eye loss, and then they go through the whole process, and then they end up with only a 30% certification. So it's good to tell them right then and then that it's, one eye phthisis, other eye 6x6. There's no point going through the whole process because it's just going to be 30%, because they think it's going to be 50%. It's like sort of psychologically somebody feels I've lost one eye and I should be 50%. So this is just a little pointer to people in the clinics when you have a patient like that. Now, the significant visual impairment that cannot be corrected, of course, these are the common causes, and it can happen irrespective of age, gender, and other factors. And the visual disability fact sheet, we've already gone through that, so I will not go over it again, but I want to here emphasize that the burden is huge. And in our country itself, let's focus on our country. Let's say that what can we do, and in our own clinics, we must make sure that anybody whom we can help, we can help. And here, as you can see, India is also pretty high. So therefore, we have to make a pledge that we're going to take care of this problem in our country. Now, what is the status update? As you see that, different surveys, statistics will use different parameters, so the values may be a little bit different here and there. But I would like to mention that even corneal diseases can be quite high, depending upon which kind of statistic you've used, which survey you've used, what is your the purpose of your study, and so on. So these are the important causes in India. And what are the consequences? Don't forget that it affects their life, their self-being, their self-worth. And it's important that if you have a child with impairment, it's very important to educate the family and give them guidance as to what are the ways in which that child can be helped with education and lead a fruitful life in future. So we found that often we were having situations where we were not actually doing enough. Being an Apex Institute and being the tertiary care center, the best in the country and all, we felt we were not doing enough, and we looked at establishing a disability inclusive eye health program in our center itself. And I would encourage that even in the OPD, if you find a blind person being just left in your OPD and then nobody to help that person, call the patient care counselor. It is the patient care counselor's duty to accompany the patient. The blind person in our hospital should not be left to just search around and find himself going from here to there, asking security guard, where do I have to go, and so on. So each one of us has that responsibility that a person should be treated with dignity, and it should be facilitated in our hospital. So we wanted to start this National Research Center for low vision and rehabilitation. Its idea is to empower and establish a state-of-the-art research and training center, and we have to begin with ourselves. So first we had to educate ourselves. It took us some time. So this was started in 2015. It's taken us some time because we ourselves did not know much about it. It's not covered that much in the normal ophthalmology training. And just to give you a snapshot about data, you see, data is going to come depending upon how it's collected, why it's collected, and also the seriousness of people who provide that data. Now, if you look at the RPC annual report, it's good, of course, that the low vision aid clinic is showing highest after orthoptic and squint clinic, but it may also mean that some of the other clinics, the people are just coming directly and may not have gone through the system and may not have been registered. Or patients with those diseases may be being seen directly in the OPD and not being registered in the clinic. But nevertheless, I'd like to appreciate this one person, Sneha Agarwal, who in the term of 5 years, she's seen all these patients with the help of the support of the optometrists that we've been provided through CBM, a huge number of patients. And as you would appreciate from the previous talks, that it's not easy. It's not simple 2-minute, 3-minute job. You have to spend a lot of time engaging the patient, finding out and trying to establish what is the best device to use for that patient. So here I would encourage that we should think of a method of modeling where based on all the data that we've got, we put it into a computer which will crunch that data and tell you in future that if you have these characteristics, these are the devices that you should try. So this is our goal after a few more years of data collection, that we will have a model so that you can, feed the information in and you come out with a kind of a relatively narrowed down option that this is what we should do. So this is the aim of the low vision services. And as we said, the idea was augmented delivery. And here again, if you saw the community and the data which Dr. Tanveer also showed, that actually it is the women who have more illness. But if you see in the terms of the data from a tertiary care hospital, we have males more than females. So this only means sort of augments or sort of emphasizes what people were saying earlier, that we require to have primary eye care delivery because the ladies are not able to come to the hospital for treatment, and we must give them that help in the community. And we have new and follow-up patients and the various patients screen. And here also I would like to say, as we have emphasized below, that even low vision can be improved with refraction, and it takes a lot of time. If you have a person who has, say, a mental disability or some hearing problem or speech impairment, that person cannot be refracted in few minutes. So a large component of patients also came for more complex refractions, including people with, very complex ectasias or complex corneal problems. So as a distribution of anatomical side, this already has been covered, glaucoma, myopia, etc. And here I again want to emphasize, so we really need to augment our refractive services because the patient should not have to wait months to get an appointment to get a refraction, and particularly some of these patients, particularly children, require more time. So that's something that as a hospital, in our center itself, we need to work at harder. Gender and geographical distribution, again, this is different from different states. Largely, as you can see, it is from North India. South India has already well equipped with 3-4 centers giving very good low vision services. And teleconsultations were a huge help during the pandemic. And here I'd like to acknowledge all the help given by all the senior residents and the junior residents and the optometry staff who were able to support the patients through this difficult time. And the pattern of treatment, here again, this is a variety. So this is the data which I don't want to go through now, but this kind of data, if we're able to use modeling, we will be able to come through with a more simplified method of shortening this chair time, and rather than the patient having to try different devices, go home, try it, etc. The other good thing has been that, as everybody has emphasized, this is a very expensive area. Patients find it difficult to afford. So therefore, we have had the ability to distribute some free devices with the support of CBM. And we were very glad that they gave us these devices initially, because in the government system, it takes a little time. It's excellent, but it takes a little time to procure things. And often there would be nobody coming for the tender to come and provide the devices. So we had this, and then we had, because we were able to get the devices, we were able to train ourselves. Honestly speaking, in the beginning, we had to train ourselves, and now we're in a platform that we can train others. And even the residents and optometry students have now been posted. And we had this low vision workshop, and by brainstorming with the other faculty members, we were able to understand what were the important aspects to be covered. Then we reached a stage where we could train others. So we reached to training of trainers of the RIOs, and as Dr. Praveen Vashish says, now we are going to plan all the other aims, connecting and coordinating with special school and rehabilitation services. And here I'd acknowledge the great help from community ophthalmology, Dr. Suraj, because here now we're going further. And as I said, the information that we get from the clinics in the hospital, that we can then take to the community better equipped to give them a proper solution. And so this was the expert group meeting to develop a national eye plan for achieving universal eye health in India. And pediatric low vision and rehabilitation, again, a huge challenge. We have Professor Leah, who guided us in this matter. And therefore, in the term of strengthening and low vision and rehabilitation services across the country, we held a national workshop. Several scientific papers and presentations have been made. And this is what I mean. You have a variety of choices, and it's not necessary that the most expensive device is the best for a particular patient. Here again, we need to do some more modeling and find out with practical use and feedback from the patient. So this is what we have initiated, a follow-up with the patients, and that follow-up data is now being entered so that we get to know, because a person may have got the device and it may be just lying in a cupboard, another person may be using it very fruitfully. So this is the information that we require, and as I said, the RP Center has then, with the help of all the data that we presented and all the requests, so now we have been given a dedicated additional section to expand for retina, plus we have been able to have an incubation facility with aims for indigenous devices, and high-end digital load devices have been purchased by the center. This is important because before a person decides to spend the 2 lakhs or 3 lakhs to buy a particular equipment, if they can get to use it in the clinic and see for themselves what it is and how difficult it is or easy it is to use, that makes a huge difference. And similarly, teaching and posting of students, interns, and residents, and observation and training, now we have requests from other places that they would like to come here for training. This is the new facility which Dr. Tityal has kindly given for the retina cases. And this is example of some of the glasses. And so critical factors, service related, socio-economic, demographic related. And here you need to be very sensitive in talking to patients. Just like you counsel a patient for IOLs, you need to be very sensitive. You must not be, sort of outright make the patient feel that they cannot afford something, they should not feel disadvantaged, etc. So you have to be very careful about that. So sensitization of eye care providers. So be very humane and be very conscious about how you talk to the patient, how you approach them. Please, in our center itself, as I said, please make sure that the blind patients are given adequate help by the patient care coordinators, and give your suggestions. Usually you'll find that if you give a suggestion even to the sister in charge in the OPD, they will take it forward and it will get implemented. And a channel for follow-up has now been put. And then what operational research and modeling of low vision services, there's lots to be done. And here I'd like to add, when I had this concept, I was recently introduced to this concept of disability inclusive eye health. And then we realized even the people who have cosmetic disfigurement, they require to be given a customized prosthesis. Again, an area which is lacking in our facility. So this is an extra thing that we need to do, that we need to look at cosmetic prosthesis. We have children with retinoblastoma and many other patients with orbital diseases, etc. So this is the other thing that needs to be looked at. Innovation and a brainstorming platform. Please feel free to give your suggestions. Dr. Parijat is here. He has given many useful inputs for his patients with ROP. And please use the facilities. As I said, there's the low vision that we can do of helping patients with residual vision or enhancing their available vision. And then you go on to rehabilitation, which is going to be covered next for the people who have absolutely no vision, and how do you help them to engage with their life. So more robust studies, active area of research, data is important, image processing algorithms, and a multidisciplinary perspective, because now we're also looking into aspects of people with multiple disabilities. They may be hearing impaired, speech impaired, cognitive impairment, and at the same time they may have some vision. We often operate children with very young children with corneal opacities or cataracts. We have very primitive ways of assessing how their life has changed after that intervention. So these are some areas that we need to look into, and way back to smiles, because even the smallest change from seeing nothing to seeing something, for example, we often disregard as vision of 2/60. But a patient who has glaucomatous optic atrophy, corneal opacity, gains vision sometimes of 2/60, 3/60, that person becomes independent. So that is something that should not be disregarded. And thank you very much. I would like to thank my co-chairman, and Dr. Bhavna is online, so is Dr. Pradeep Venkatesh, and all the speakers for all the efforts in putting this session together. Thank you so much. So should we invite the next session? Yeah. So I'd like to invite Dr. Suraj to please take over for the next session on rehabilitation.
Thank you, ma'am. So now, moving ahead to the next session, that is vision rehabilitation. So we have our colleague, Professor Parijat, and online we also have a director from NIBH, Dehradun, Dr. Himanshu Das. Dr. Himanshu Das, you there? Dr. Himanshu Das? We would like to listen to your voice. Okay. So this vision rehabilitation is very important as well as a part of the continuum of the service for patients who have.
Am I audible, sir?
Yes, yes, audible. You are audible. You can switch on your video as well, camera.
Am I audible?
Yes, yes, you are audible. Please switch on your camera. Dr. Himanshu? So Dr. Himanshu is the director, NIBase. The NIBase now the name has changed to NIEPMD. So the NIBase is one of the national apex center in terms of vision rehabilitation. So there are lots of works going on apart from the education, other vocational training center. So we are lucky to have Dr. Himanshu Das. So he will be talking on the schemes the government of India under the Ministry of Social and Justice Empowerment. So schemes for visually impaired persons. Dr. Himanshu Das. I think
Dr. Das, you are there, you can start your lecture.
Am I audible, sir?
Yes, you are audible. You can start your lecture, sir.
Thank you, sir. I'm so sorry. Very proud privilege to be part of this very esteemed gathering. My honor is the co-panelist.
Sir, you have to share your screen.
I don't have a PPT, sir, because of some reason I couldn't get it.
So then you can turn on your video, sir. Nice. Yes, we can see you now, sir. Yes.
Thank you so much, sir. Thank you, sir.
You can start your lecture, sir.
My salutations to Dr. R.P. Center for Ophthalmic Science AIMS, and the very esteemed panelist and chair. Very humbling to be part of this esteemed gathering. Professor Radhika Tendonji and Professor Thank you so much for giving opportunity. This is a very huge topic to be covering in a little while. So I'll give you the gist of whatever we have right now. So currently, if you talk about the central government, sir, we've got the National Institute for Empowerment of Persons with Visual Disability. That is offering a kind of a holistic service for persons with offering services, holistic services to persons with special needs, starting from the school, full-fledged residential facility, a school, then we have got a lot of other services. We have got an IPI for persons with visual disabilities and host of other services. My presentation later will talk about all of them directly or indirectly. Government of India has got also a project under the name Composite Regional Center. Composite Regional Center, where we have a state-level comprehensive multi-disability service institution across the country. Then we also have a scheme for District Disability Rehabilitation Center. So every district, we got to have a comprehensive District Disability Rehabilitation Center. Further, we have certain regional centers. And last year, we came up with the option of Cross-Disability Early Intervention Center. Now we have about 14. So hopefully by another 2-3 years, we'll be able to have over 30 Cross-Disability Early Intervention Center with facilities for individuals with visual disabilities. Now we also have got a scheme by the name DDRS, Deen Dayal Upadhyaya Scheme. We have got very many projects which can serve persons with visual disability. For example, we have got a project for preschool, special school, residential special school, low vision center, community-based rehabilitation center, home-based lab institution, and also human resource development program support system in terms of primary teacher production, DED in special education, visual impairment. Apart from that, we have got an umbrella scheme by the name SIVDA. Under that scheme, we have an enormous opportunity for skilling of persons with visual disability, accessibility for persons with visual disability, awareness generation programs for persons with visual disability, and R&D programs for persons with visual disability. These are comprehensive kind of institutionalized facilities that we are giving. For individuals with disability, we have got a scheme by the name is ADIP scheme, Assistive Device for Persons with Disabilities. Another scheme across different age and bifurcated to low vision and by blindness, we have got both teaching learning aids and also assistive devices, those are given. This year, the range has been up to 15,000 per person. So from age 0 to adult group, we have divided it into two kind of, across different ages, divided two kinds of facilities. One is for low vision, one is for blind. So devices can be distributed across the country. And we all know there is 1% job reservation in all state and central government jobs, including PSUs. Higher and technical education, we have got reservation for persons with visual disabilities. And we have got a enormous scholarship scheme. Under that, we have got pre-matric, post-matric, higher education, technical education, overseas scholarship as well. Then there are a lot of small things which are making difference in small segment, although may not have been popularized much. For example, the house allotment preference, income tax rebate, allowances that we give to persons with visual disability, travel allowances in bus, railways, and also air, education-related provisions like scribe, extra time, subject choice, plus curriculum. Those are a lot of such provisions. We now have about a Braille press scheme for all students in the education system. We have got 29 Braille presses across the country, catering to different languages. Every child can get this Braille book free of cost. Similarly, for low vision, we have got large print book, which Samagra Shiksha Abhiyan has got the grant for the large print book. They can order large print book from us, and we can provide them large print book that aids low population. Also, we have got system for audio books and books. For the audio books, we have got talking book library system, and for the digital accessible book, we call it National Accessible Library. So anybody can be part of it and take accessible services. And also Central Government Postal Division has got free postage of all Braille documents and appliances. So we have got a special bag wherein we can supply Braille books free of cost from our library, sit over anywhere across the country, and the person can use those books and get back to us. Similarly, phone connection preference and facilities are there.
lot of custom-related preferences we can give. And further, if you see, we have got admission reduction also in higher and technical education in terms of percentage. Sometimes 5% in general, sometimes there are other percentages specified. And we have also got a national fund for persons with disability. Under them, we can propose for very many things, including promotion of specific skills that a person with disability has in terms of art, craft, or any other complete skills that a person has got. Then we have got a bank specially meant for persons with disabilities under the name National Handicap Finance and Development Corporation. So that offers a low-cost loan individuals and also organizations, those who are serving persons with visual disabilities. And for legal matters, we have got state commissioners for disabilities and there is a chief commissioner for disabilities at Delhi. Those are quasi-judicial organizations. They support in terms of advocacy and legal provisions for persons with special need, and also has got a national award scheme wherein we try to promote role models in the field of disability sector, including persons with disabilities and those who work for them. Then further, Samogra Shiksha Abhiyan has got a massive outlay across the country. From 10 years, so a lot of work is going on under Samogra Shiksha Abhiyan as well. In the higher education institution, we have got equal opportunity where they try to offer as best services to persons with special need. Also, persons with special need are part of the SEDG group, socio-economically disadvantaged group. So higher education has got a guideline, it has got a guideline for socio-economically disadvantaged group. There also we have got this provision for supporting persons with special needs. There is possible plans that are coming up from the UGC 360 guidelines for higher education. All companies are offering dealership provisions and loans and interest rates in different banks. Public sector undertaking has got certain provisions for it. And subsidy in integrated rural development program. This is a massive program of Government of India. There we have got subsidy for persons with visual disabilities for integrated rural development programs. And also the central government and different states have completed the job identification procedure for persons with visual disabilities and likewise other disabilities. So we are hopeful that job reservation and employment will take place. And there are also employment age relaxations as well for persons with visual disabilities. And it's further to submit that there are a lot of state-related specific provisions, say pension-related provisions, unemployment allowance-related provision, employment generation programs. There are a lot of marriage-related specific schemes of the state governments, state bus services. There are state-specific reader allowance. Sometimes they provide laptops. This is nutshell of what the whole gamut of policies, schemes, and benefits and concessions for persons with visual disabilities. Thank you so much, because my time was very less. I thought this was precise enough. Thank you so much, sir. I'm very sorry for the poor connectivity.
Yeah, thank you, Dr. Himanshu Das. You know that many times our resident doctors, our ophthalmologists, they are not very much aware of this basic scheme under the Ministry of Social Justice and Empowerment. From our end, Dr. Himanshu Das, we would like to request one thing that, our center aims, we have established this low vision and vision rehabilitation service, and we also collaborate, we also met some kind of networking, those NGOs and those schools for the blind in Delhi and NCR. So what happened is, we are very much shortage of assistive device that we, here in our center, every day, say nearly around 30 to 35 patients with low vision and blind are being registered, and then we are not able to provide this assistive device. Simple, for example, a walking cane, because many patients, most of the patients who register here are from the, very underprivileged and from the poorest of the poor, I mean to say the below poverty line. So, like if possible that the NIBS provides some kind of device under this scheme. So for example, ADIP schemes, I'm very much aware of that. ADIP schemes has been revised recently. So if possible, if we are able to develop some kind of networking so that we can get some devices and then further we can dispense to those very much needy patients. So that kind of system, if we develop, because I know that the Ministry of Social Justice and Empowerment and Ministry of Health and National Welfare. So we have a two parallel ministerial division. So if possible in the future, and we have a Professor Radhika, who is the chairperson of our low vision and vision rehabilitation. So we can, develop some kind of, networking so that we can get some devices from your end. So what do you suggest?
It will be honor and very, very proud privilege for me as director of this institute get directly associated with your department and visit, connect all the other aims ophthalmic service department, ophthalmology department. I have signed a small MOU with Rishikesh AIMS ophthalmology department. Also signed a MOU with the Bilaspur AIMS, but this will be piecemeal kind of a work. So I would be honored if we could sign a comprehensive MOU and start giving whatever services, little services we can, and whatever enormous services we can also get from your end, because medical management of persons with low vision is a very core area which we are seeing for. So I'll get to you formal project.
Definitely. So under the leadership of our Professor Radhika Tandon, so we will definitely think of to have some kind of MOU so that we can get those magnifier, those rehab devices. It will be very huge benefit for those patients coming to RP Center. Thank you, Dr. Himanshu Das. Thank you.
So now I would like to invite Dr. Suraj Singh Sanjam to talk about overview of low vision rehabilitation. So Dr. Suraj is very passionate about LVA, and he really likes to do it with a lot of dedication and care, and it will be interesting to hear about his thoughts on this.
ये स्लाइड नहीं था, ये तो पुराना है. This is another one. यही कॉपी क्या था? This is another one. Hold on. ये नहीं था. ये मेरा ईमेल खुलेगा. हाँ, खुल जाएगा ईमेल में. ये नहीं था. तुमने सही कॉपी किया है ना? यहाँ से सही कॉपी किया. So I think we have a wrong slide. So I think before I present, so Sumit, you can present so that I can get the correct slides. Sumit, please.
Till Dr. Suraj fixes his slides, I'd like to invite Dr. Sumit Grover to talk about disability certification of low vision.
Thank you so much, sir. It's indeed an honor to present my work and to showcase what is the session on vision rehabilitation in front of stalwarts like Professor Radhika Tandon and our mentor, Dr. Suraj Singh Sanjam. This is an important topic, and I'm very much glad that already the stage has been set by Professor Radhika about the low vision rehabilitation and disability certification issues. In this session, there are many students, optometry students, and I like them to, freely discuss, contribute, and ask questions. And please kindly note the take-home messages. This is just to recapitulate the categories of visual impairment. Before going to the disability certifications, we have to understand that what is blindness, what is visual impairment. If you see the category 1 and 2, this is the latest classification. Previously, these category 1 and 2 were classified as low vision. But in the latest classification, these have been divided into moderate and severe visual impairment, and blindness is presenting visual acuity of worse than 3/60. And this has been further categorized into category 3 and 4, but they both come under the blindness. The International Classification of Impairment, Disability and Handicaps, ICDH-2, in the late 1980s defined disability as any restriction or lack of ability resulting from an impairment in performing any activity within the range considered normal for human being. It was actually the very basic medical model. It lacked the social model in which the barriers posed by the society to the individual with disability were not considered. But by the advocacy and the leadership and the learning experiences from the low vision specialists around the globe and the leadership of the disability organization around the globe, because of these advocacy, disease issue. Disability should not, they advocate that disability should no longer be viewed as merely a result of anatomical impairment and only the activity limitation, but the participation restriction because of the consequence of negative interaction of these components with the socio-economic environment of that individual. So that the social model has been integrated with the medical model. So as we go through there was a very excellent slides by Dr. Tanveer Alam and Dr. Amit Das, but if we analyze the cause of visual impairment from 3 decades later to now, we can see the diseases like trachoma, vitamin A deficiency were very easy to manage, like one-time MASDEC administration, primary eye health care could have sorted out these things. But then came the cataract refractive surgery, and now we are in the era of complex diseases like glaucoma, DR, ARMD, and retinopathy of prematurity as also is making a significant impact and global burden on the low vision impairment patient around the globe. So the increasing complexity, increasing age, and lack of resources, make all these things, we have a very much significant role to play in this regard. And these are the common diagnoses we find in LVR clinic in our RP center setup, and we can see there are all the complex disease. Now I'll after this brushing up of these all concept, I'll come to the core topic of my presentation, which is Government of India Guidelines for Disability Certifications. And in her previous slides, Professor Radhika has already highlighted a very important point that we have to give a permanent certificate to a person and not a temporary, but there are a few exceptions. And if we don't know about how to give a disability certification, how can we guide our patient? How can we talk about the if we don't know what is a benchmark disability, how can we counsel them that there are many schemes which have been comprehensively highlighted by Dr. Himanshu Das in the previous slide. So all these guidelines, certification guidelines have been issued by the Ministry of Social Justice Empowerment. And the United Nations Convention on Rights of People with Disability was a very, was a change maker. And it was a global convention under the aegis of United Nations, which ensured that every participatory signatory country has to have has to have norms and legislation to provide security, independence, and social protection to all the disabled population of the country. And there are 8 subcommittees and 21 disabilities now. Previously, there were only 7 disabilities, but in the latest guidelines issued by Ministry of Social Justice Empowerment, there are 21 disabilities which have been listed in the Gazette, and blindness and low vision is among one of them. And in the Ministry of Social Justice Empowerment classification, the blindness is defined as total absence of light or visual acuity worse than 3/60 in the better eye after best possible correction. It is a slight difference, nuance of presenting vision and best possible correction. Then the limitation of field of vision, subtending angle less than 10 degrees. So the visual field less than 10 degrees is also a should be categorized as blindness. And low vision is a visual acuity less than 6/18 up to 3/60. Although the functional definition low vision, which has been highlighted by Dr. Amit Das, stated that the low vision is less than 6/18 to the perception of light. So these are subtle differences between MOS, JS, empowerment definition and the WHO classifications. So these are the old categories of blindness using which we were used to give the disability certification, as mentioned in the first and foremost slide of Dr. Praveen Vashisht, if you all remember, that these were very difficult to use by the ophthalmologist, and very much confusing and disadvantage were given to the patients. And the certification criteria and gradation of visual disability has been revised. And now the latest classification is like this, in which there is disability category 0, 1, 2, 3A, 3B, 3C, 4 and 4B. And the one-eyed patient is has been given the 30% disability. And the problem with the previous classification of disability was all the patients were categorized between, there was no gradation like 0, 10, 20, but there was like 0, 20, 40, 75 like this. So this has been taken into account more and more things into it, and also the visual field categorization. Also, the most important thing, I think, which all the optometry students and the resident student here should carry with themselves this matrix. It is freely available under the Creative Commons license, and this is a very easy tool to gauge the disability. You have to see the Snellen's vision chart, equivalent best possible correction of each eye separately. Then you have to see that in the row, the best corrected visual acuity in the right eye, for example, is 624, and then you go to the left eye vision, and if you see the best corrected visual acuity is 1/6, then simply you can say that the disability of that person is 60%. Very, very intuitive, very, very easy to use, and has very less chance of you can be wrong. And what is the percentage of disability is just an example. If the BCVA in the right eye is 160 and the left eye is 660 or better, I think anyone can answer here, and it is 60%. 60% as well as the revised guidelines. And this is also collaborating with this matrix has been designed so that the algorithms are matching with this latest disability guidelines. Also, for the field of vision as well, we have the matrix, and easily with the field of vision of the person, we can just classify the patient into what category of disability he and she belongs. And already highlighted, the person with benchmark disability is 40%. The one-eyed patient have 30% disability, and they're not eligible for any of the government sponsored schemes. The nature of a certificate can be temporary or permanent, but has to be permanent, and as suggested by ma'am, and temporary only in certain circumstances where the students need an admission into college or school or something like that. And there are many progressive disorders like retinitis pigmentosa, keratoconus, etc., and operated congenital cataract with amblyopia, where a temporary certificate of disability can be issued. There was a time in 2001 that disability certificate only could be issued by a medical board duly constituted by state and government bodies with at least 3 members, which was a complex thing. But now the things have been made easy, and only one ophthalmologist can certify the patient after the thorough clinical examination, but should be countersigned by the medical superintendent and chief medical officer or civil surgeon of that district. So things have been streamlined and made easy so that the disabled should not struggle so much for their certification. And there is no age limitation for beneficiary for any disability certificate. And now I'm towards the conclusion of my slide, but how to assess the multiple disability. This is very important, because if the person coming to us is visually impaired, he or she could have a hearing impairment, can have a locomotor impairment. So how we judge the final disability in these kind of patients? So the formula given is A plus B, 90 minus A, where the A is the highest score and B is the lowest score, and this score shall not be exceed 100%. For example, if the hearing disability is 30% and visual is 20%, by applying this formula we get the disability of 43%. And for certifying more than 2 disabilities, each disability is evaluated separately, and then degree of disability is calculated by the notified specialist in that area. A ENT person will give the hearing impairment, and the ophthalmologist will give the visual impairment. And based on the score received for each disability, they are graded from most severe to least severe, and then it can be put into this formula of AB minus 90. The last thing, the unique disability ID, it is the project being implemented with the view of creating a national database for the people with disability and to issue them with a unique disability identity card. It will be integrated with the Aadhaar card, with the passport and other relevant government documentation. It will be a single document to be carried by patients with people with disability, so there will be less chaos and more streamlining. And the information on the brochure of Government of India scheme for the people with visual disability has been published by our Low Vision Rehabilitation Center by Dr. Tandon and Dr. Suraj. It is also easily available. Those who are interested can contact us for this. Thank you so much.
Thank you, Dr. Grover. That was very insightful, and I think it gave the audience a lot of guidance about the different criteria and categories of blindness which are there, and it was very useful. Thank you so much. So now I again like to invite Dr. Suraj Singh Sanjam to talk about overview of low vision rehabilitation.
So you can share your slides. Actually, we are running out of time, so I will try to finish as early as possible. So anyway, as I said, the rehabilitation is one of the very important area in dealing with the person with disability, irrespective of types of disability, maybe visual, maybe hearing, maybe locomotor, maybe cognitive. So this rehabilitation part, while managing a person with visual disability, is one of the very important components. So while managing a person with low vision, and total blind, so we need to go hand in hand, the clinical as well as vision rehabilitation component. So now coming to the overview of my talk, that is about rehabilitation, the vision rehabilitation. So let me go through. So first, before you go to the rehabilitation, we should know what is the definition of those various terms, when we use the rehabilitation. So many of my colleagues has already highlighted. So you have the visual disability, there's a low vision, functional low vision, and blindness. So I'm not going to detail, so let's move on. So overview of my lecture, so I just wanted to share that understanding the concept of visual disability and the spectrum of the service and visual stimulation and vision training. And in addition to this, the assistive technology for visual impairment, so which is one of the very important components while managing a person with visual disability. So that coming to the rehabilitation definition, so many books in the context of preventive medicine, so this makes the public health and preventive medicine, so there's a chapter on rehabilitation, not particularly for the visual disability. So it is an overall concept about the rehabilitation. So we know that there's a set of measures to be given to the person with disability to improve their functioning, and then obviously ultimately to be able to live independently. So this is the definitions, and the goal is to remain in or return to their home and community and live independently and participate in society, and later on contribute to the family and society as well as globally as well. So the concept of disability is earlier in 1990, WHO says there's a sequence of disease event that is starting from the impairment, disability, and handicap. So now this sequence of disease events is not more used. So the down below in 2001, the WHO revised the definition of disability. So disability includes the impairment, could be low vision, could be blindness. And in addition to that, there's activity limitation, the daily living activity limitation, and also the restriction in the participation in the society, and the social event and the festival. So disability includes the three terms. So the impairment, start with the impairment, and activity limitation in daily living, and the participation restriction in the society. So three component terms is very important. So they have developed a framework here. So you will find because of health and disease, there's a body function problems, and this will lead to the activity limitations. Person cannot write, okay, cannot do the daily living, and then further the participation restriction in the society. The person cannot participate for the social event or another festival, so that kind of things. So this chain is influenced by the environmental factors and personal factors. So this is the area where we need to focus. So the impact due to the low vision, so we know that is a chronic health problems. So it really impacts the quality of life and even the socioeconomic status and a whole range of, these issues due to the low vision. So while managing a low vision person, so we have body impairments and the social and environmental problems and assistive device. So assistive device particularly I want to mention here. So without assistive device, it's not possible to manage completely a person with visual disability. So this is continuum of the service. We should always think about starting from the low vision, the clinical component, and the rehabilitation and the community base. So in the hospital, so you can have the clinical service as well as the hospital-based rehabilitation. And further, when patient goes back to their home community, so there has to be some kind of service provision in the community itself. So this is a model for us. Currently, we are using this. In the hospital, we have the clinical area that We provide medical, psychological rehabilitation training and retraining of the assistive device, about the ADL, activity of daily living training, about a smartphone. There are so many other training and retraining components while providing the rehabilitation service. And in the community, we try up with the 75 ITs NGOs so that the service component can further continue when the patient goes back to their home. This is called a clinical social models, the clinical component as well as social component, so club together. So various manuals we have developed here to vision rehabilitation and adaptive training. So why I am saying the adaptive training is very important, because adjustment and the adaptives are different. A person with a complete total blind or permanent blind, so he has to adapt. Adjustment is for temporary. So you can adjust your seat belt, you can adjust your chair. So this is a temporary basis. For a complete blind person, you have to adapt the system. Sorry. So adaptive training is so important. So the patient needs to adapt the kitchen, the library, the school, the workstation, everywhere you need to adapt. So adjustment and adaptive, there's a difference between the, sometimes you may require adjustment, of course, but adaptive is more important while we provide a rehabilitation service. And as earlier also highlighted that vision rehabilitation for children with vision loss, which is also one of the very important coming. So this is various guidelines. So this is the activity of daily living skills training. You need to provide in how to conduct those, perform those activity of daily living and the instrumental daily living activities. To share there are a wide range of activities starting from the morning up to the end of the in the night before we go back. So all the range of activity you have to provide a training how to do those trainings. And this is various mobility is one of the very important component for indoor and outdoor movement. The person with total blind, so he or she will face a problem in movement, especially indoor and outdoor. So outdoor, what sort of training we should provide? Because without movements, the person cannot improve the quality of life. So this mobility, outdoor mobility is so important to improve the quality of life. And these children, as I said, it's very important because children with visual disability, so we need to do some, intensive training and also the clinical service so that the children can develop their milestone in the normal, in the correct way. Otherwise, there will be an issue in terms of problem, setback, delay in the milestone, in terms of cognitive, motor, so all range of milestones. So even this, when you see the ROP patient in the clinic, so when you compare with the, their development, so the milestone, they're always delayed. So similarly, their hygiene also. When children coming from the poor area, the visual disability, so their hygiene is so poor compared to the children coming with other issues. So vision stimulation is not very effective nowadays. I have done some few literature search. So vision stimulation is not very effective as far as literature is concerned, but the vision training is quite effective. So vision training is another area we need to thought of. It is related to the visual behavior of the child. So it has been proven that by the RCT, so it is quite effective for as part of the early intervention. It shows the improvement in terms of milestone, cognitive, and other skill-based, performance to a child with visual disability. So assistive technology for visual impairment, as I said, so it is one of the very important and part and parcel to manage a person with visual disability. So this is a wide range of assistive device to be incorporated while managing a person with visual disability. So briefly, assistive product is just a simple product. This is a walking cane. When you say assistive technology, it includes the product as well as the service related to it. That means the prescription, the maintenance, the training and retraining, the entire gamut of these services includes when you say assistive technology. Assistive product is just a simple product. It doesn't have to do the service. When you say assistive technology, include the service component as well. So there's a lot of area to be done in the assistive technology for visual impairment in terms of classifications. I have done some kind of classification about assistive technology for visual impairment and other area. So the classification is so important because what sort of patients need what sort of assistive device. So this is the area to be done, some research components in the assistive technology, and this identifying the potential user for assistive technology for visual impairment. When you look at this, the chart, assistive technology potential user, so you divide it into low vision up to 160 and less than 160. Why this division is being used? A person, particularly for the students, if we prescribe the magnifier, if a student who has less than 160 blindness, so that magnifier cannot be used productively. So we cannot recommend to use for reading purpose, use the magnifier, the dome. So rather than prescribing those magnifier, you go for other devices which is the sound and tactile base. So this classification is particularly important to prescribe this low vision devices, particularly for a student. See, this is the low vision up to 160 and less than 160 blindness. So less than 160 blindness, if you prescribe the magnifier, so the person cannot use effectively. So in that case, we need to think of some other assistive device. So what Buddhist hands are required to use this assistive product? This is a visual-based assistive product and tactile and sound-based assistive product. So in the rehabilitation, so we need to decide which device will be to be prescribed to children with visual disability to be able to use predictably. And this is the chart. This is the algorithm. This is particularly useful for children with visual disability for education purpose. A smartphone is another important area. So we need to, we are providing training to smartphone using some various accessible applications. Nowadays, smartphones, every of us has a smartphone. So the message is, the last slide is the visual disabilities are chronic health problems. Non-communicable diseases keep increasing, growing. So at the same time, the rehabilitation components to strengthen the rehabilitation is need of the hour, including the low vision service. And assistive technology for visual impairment is an indispensable tool, indispensable tool for the management, like a medicine. And the vision loss can be categorized, the low vision up to 160 and less than 160 blindness for assistive technology application for visual impairment. And we have the visual-based assistive technology and tactile and sound-based assistive technology. Thank you. Thank you.
So thank you, Dr. Suraj, for this wonderful presentation and sharing so many useful insights about low vision rehabilitation and its different classification and the different aids which are there. I think they will be very useful again to the audience your passion and all reflects in the presentation which is there. So now next we'd like to invite Dr. Souvik Manna to talk about case studies on LVR.
Thank you, sir. Before beginning the presentation, I would like to mention that we have taken consent from all these patients for using their photographs and videography for educational purposes. I will demonstrate some of the success stories in our low vision rehabilitation clinic. I have selected a case of ROP, albinism, retinitis pigmentosa, optic atrophy for today's presentation. So these things have been already talked about in the previous presentation. The first case study is a 15-year-old boy who came to us from the retina clinic for the first time when he came to our clinic from Rajasthan, and he complained that he was having difficulty with his vision, with his distance vision, which hampered his education, his social activities, as well as he was having some peripheral visual field restrictions. His best corrected visual acuity was 6/18 in both the eyes, but he was not having any disability certificate. Our medical social worker counseled him and provided him all the assistance for getting a certificate of disability. He was provided a trial of optical devices as well as an individual visual rehabilitation plan comprising of his rehabilitation needs was prepared. In this video, we can see the child being provided a demo of a telescope. Can we have a video, audio? So using the telescope, there was an improvement in his distance visual acuity, and he was followed up, and he was happy with the assistive product. Of late, we are seeing a huge number of cases of ROP in our clinic. Because of improvement in maternal and neonatal health, this has become a very big cause of childhood blindness in our country. A 4-year-old boy presented to our clinic, referred from the retina unit. He was having history of prematurity, born at 37 weeks, and he was admitted to neonatal ICU for a few days. He was not having perception of light in any of the eyes. In such cases, a child of 4 years, we had prepared an individual visual rehabilitation plan, and we provided him stimulation techniques to the child. A kiddie cane was demonstrated to the child, and you can see how a child used this cane as a toy and then learned the use of this kiddie cane.
बच्चे जो शरीर पकड़ने का स्टाइल जो है टेक्निक है सीखेगा नहीं है बट उसको तो जैसे समझ जाएगा उसको पता चल गया ना कुछ है हमारे पास है दे दो उसको हमारे पास कितना है हाँ दे दो जैसे ना सुनो आ जाओ मेरे पास आ जाओ मेरे पास आ जाओ एकदम जैसे कर रहे थे नेचुरल ये एकदम ले बोल So here I want to say that you cannot dictate a child to hold the walking cane correctly. So the small child, if I say you hold like this, child will not follow. So whatever child feels comfortable, so we need to, agree. We have to agree. हाँ, अब किस तरह से walking cane पकड़ोगे, and then we cannot dictate, we cannot ask them do like that, like that. So child will not follow because child should think this cane is a toy. Otherwise, child will never use this walking cane. Children can. That's the message.
One of our success stories is this 18-year-old boy who is a national level cricket player. He is having optic atrophy since birth, and he is not having light perception in any of his eyes. But due to successful training by our team in Android-based apps like Be My Eyes, Visor, TapTapSee, Money Reader, Super Sense, he got admission in school, and now he is a national level cricket player in the blind and low vision team. This girl, school dropout, case of iridofundal coloboma, 22 years female with the chief complaints of difficulty vision and mobility, perception of light negative in left eye, 360 in the right eye. So our team trained her in mobility techniques using a sighted guide, also gave her a demonstration of Victor Reader, as a result of which she got admission in graduation. She started her education again and had an improvement in her life. So here we will demonstrate the sighted guide techniques using a sighted peer, and also how to navigate obstacles.
आप यहाँ पे आ गया नहीं आप इस तरफ देखो आप वहाँ ले लो देखो हाँ ऐसे एल्बो में यहाँ भी पकड़ना होता है ठीक है तो यहाँ आप आगे जाओ हाँ ठीक है तो हमेशा ऐसे ही पकड़ लेना लेकिन आप खुद एक्सपर्ट होने के बाद आप पूरा कंट्रोल पोजीशन चेंज कर सकते हैं अगर कोई थोड़ा सा नैरो पैसेज आ गया है तो आपके पीछे हाँ वहाँ पे जाना है ठीक है ना मैडम के पीछे अगर थोड़ा सा अगर वाइट पैसेज में आ गया तो आप सीधा साथ में जा सकते हैं हमेशा एल्बो में पकड़ लेना ठीक है ना और आपको बताना है यहाँ पे दरवाजा है यहाँ पे ये है आपको ये जरूर पता क्योंकि आप एक्सपर्ट होने के बाद जो आपको जो गाइड करते हैं ना वो बता देंगे आप मेरे को बताइएगा यहाँ पे कुछ स्टेयर्स आ रहे हैं यहाँ पे दरवाजा है यहाँ पे पोस्ट है खंबा है आप
The last success case story is that of albinism. This 42-year-old woman regularly followed up in our clinic, having 2 kids. She is educated up to BTech. So her BCVA 660 in both the eyes, and we had been providing her follow-up since few years. Refractive error was corrected. Illumination control was advised with the help of sun lenses, tints, UV protection, visor hats, magnifying devices. Hand magnifier was prescribed to her, and visor training through our assistive technology mobile application was also taught to her. So let us see how this independent and white cane mobility techniques were. So in this video, we saw how the self and independent mobility, trailing techniques, upper and lower body protection, etc. were demonstrated to our beneficiary. In the post-lunch session, we encourage you to visit our clinics where some of these optical aids and non-optical aids are being displayed in our clinic. Please do take the time to visit them. Thank you for the patient listening.
Thank you, Dr. Manna, for this excellent case presentations, and I think it really provides good insights that we usually leave these people for blind, but how the Department of Community Ophthalmology and low vision assistance helps to rehabilitate them and give them a new life, make them socially empowered, make them able to move about and do their activities of daily living. So thank you so much, Dr. Manna. So, so that's the last session. May I request Professor Radhika Tandon to say a few words, and Professor Praveen Vashisht, if sir is here.
I'll ask Dr. Praveen because he's been the spearhead of this entire workshop. And there's no words to say, the great contribution everybody is making. And I really appreciate all the people who've been working behind the scenes and all the faculty and residents who've taken trouble in preparing the presentations. Over to you, Praveen.
Thank you, thank you. In fact, it was all the initiative and plan from Dr. Radhika Tandon's side only, and we try to execute that. In fact, after this we have one session. That's basically practical session, in which I'll request that Dr. Suraj, the team can be divided into 2 groups, and Group A and Group B. The first group can go to low vision clinic, and the second group can go to the vision rehabilitation clinic. Low vision clinic is at first floor, and Mrs. Sneha is there. She is our optometry consultant, and she'll be taking care of it. Whereas for vision rehabilitation clinic, this is at 7th floor, and our team from Community Ophthalmology, they'll be taking care of this thing. And in fact, after 45 minutes, both the team, they can change over, and the team A, which is going to vision clinic, so low vision clinic, they can come to rehabilitation center, and other way around. But in the last, I must thank all the speakers and were there given their time to come here and deliver fantastic lectures. I'm really thankful to all the delegates who are there in physical mode as well as in virtual mode. And this workshop is, I believe, the first workshop in community ophthalmology low vision. And I'm very thankful to all of you. It's a grand success. And sincere thanks to all the people who were involved in organizing this workshop, whether team from community ophthalmology side, whether low vision team. And I request all of you to join for the lunch now. Thank you very much. Thank you.